Welcome to Know Your Nets, a program created for patients and caregivers navigating neuroendocrine cancer. I'm Elise Gellerman, CEO of Neuroendocrine Tumor Research Foundation. We are honored that you are joining us. Know Your Nets is now in its 7th year. This program is designed for you and, in a way, by you. You told us what you want to learn through our spring patient survey and past conference evaluations. Today, you'll hear directly from leading physicians and researchers about the latest neuroendocrine cancer treatments, exciting developments in research, plus inspiring thrivership stories. We also have some new features this year, so stay tuned. If you are new to NetRF, we are the largest global funder of neuroendocrine cancer research. Since we were founded by a patient more than 21 years ago, we have invested $41 million to support scientists who are discovering how this cancer starts and developing new treatments to stop it. We are committed to funding breakthroughs today that lead to more treatment options for you tomorrow. And we educate and empower patients and caregivers. The more you know about neuroendocrine cancer, the better equipped you will be to make informed decisions about treatment. Through thrivership, you will learn that you are not alone and, we hope, have tools to manage a cancer diagnosis. So here's what we know about you. 75% of our audience is patients, and another 19% are caregivers. While the vast majority of you are from the United States, we have a total of 28 countries represented among those who registered. For 62%, this is your very first neuroendocrine cancer education program, so we especially welcome you to this community. About a third of you, 31%, have been diagnosed within the past 1 to 2 years. Whether you're newly navigating this disease or further along, you belong here. Know Your Nets is a team effort. We are grateful for the many neuroendocrine cancer experts who will be speaking today. We thank our sponsors, AbbVie, Boehringer Ingelheim, Curium, Crinetics, Exelixis, ITM, Lantheus, Novartis, and RayzeBio. Know Your Nets would not be possible without our co-sponsor, University of Chicago Medicine, and especially Doctors Xavier Koitkin and Andy Liao, who have partnered with NetRF to design this program for you. Dr. Koitkin is a surgical oncologist with expertise in treating neuroendocrine, thyroid, parathyroid, and adrenal tumors. He is assistant professor of surgery and director of the University of Chicago Neuroendocrine Tumor Center. Dr. Liao is a medical oncologist, associate professor of medicine at the University of Chicago, and co-director of the Neuroendocrine Tumor Program. He treats GI neuroendocrine tumors and hepatobiliary cancers. Now, a few words from Dr. Koitkin and Dr. Liao.
Welcome, everyone. I'm Xavier Koitkin. I'm one of the surgeons at the University of Chicago Medicine that specializes in neuroendocrine tumor care. I'm glad to have you here today. We are really excited for a fantastic program, and my co-chair here is Andy Liao.
Hi, everyone. Welcome. I'm Andy Liao. I'm a medical oncologist from the University of Chicago. And this year, we have another exciting agenda. We actually reach out to neuroendocrine tumor patients and caregivers and send them surveys on what they want to hear about. So this agenda is crafted based on the feedback from our patients and caregivers. We also have an all-star panel of experts, speakers, and panelists who are all experts in their field from all over the country, and they'll be sharing the exciting updates this year on neuroendocrine tumors. So I hope you all enjoy and learn a lot from today's conference.
Thank you, Andy. And the first segment in our program is your neuroendocrine cancer journey from diagnosis to ongoing care. Dr. Liao will share the latest on recent advances in the clinic, what's new in neuroendocrine cancer treatment, and clinical trials.
Hi everyone, my name is Andy Liao. I'm a medical oncologist from the University of Chicago. Today, I'll be presenting on recent advances in the clinic, what's new in neuroendocrine tumor treatment. We're going to start by talking about updates in PRRT, moving on to talking about novel targeted and immunotherapies, and ending with some practical guidance for clinical trials for neuroendocrine tumor patients. So to recap the systemic therapy landscape for well-differentiated GI and pancreatic neuroendocrine tumors, we have somatostatin analogs typically used in the first-line setting, including octreotide and lanreotide. We have PRRT with lutetium dotatate or Lutathera that's approved for the second-line setting, but there's also data for its use in the first-line setting. We have targeted therapy options including everolimus, sunitinib for pancreatic neuroendocrine tumors, and cabozantinib. And then we have conventional cytotoxic chemotherapy such as capecitabine and temozolomide for pancreatic neuroendocrine tumors. So what's new with PRRT? As we all know, lutetium dotatate or Lutathera is the cornerstone of systemic therapy for neuroendocrine tumors that express the somatostatin receptor. This is approved based on a NETTER-1 study that showed that lutetium dotatate significantly improved progression-free survival compared to high-dose octreotide with an improved response rate as well. And the numeric improvement in overall survival, though, was not statistically significant. There's also data to suggest that lutetium dotatate is effective in both pancreatic and lung neuroendocrine tumors. So based on all of this data, the FDA approved lutetium dotatate as second-line and beyond therapy for GI and pancreatic neuroendocrine tumors expressing the somatostatin receptor. There's also data for its use as first-line therapy. So this is the phase 2 NETTER-2 study that showed that lutetium dotatate improved progression-free survival compared to high-dose octreotide and also improved response rates in this grade 2 and grade 3 neuroendocrine tumor population. So how do we make PRT work better? Well, there's many different strategies under investigation. Today, we'll talk about some data for combination PRT strategies, data informing treatment sequencing, and data on novel radioisotopes. We'll start with lutetium edotriotide. So this is a new radioisotope. You can see from the cartoon here, the radioactive payload is lutetium. It's linked to DOTA, the chelator, to edotriotide, which is a somatostatin analog. Lutetium edotriotide PRT was evaluated in this phase 3 COMPETE study. So this study took patients with well-differentiated GI or pancreatic neuroendocrine tumors, grade 1 or 2, Ki67 up to 20%, and they can be treatment naive or they can have progressed under prior treatment. So the patients are randomized in a 2-to-1 fashion to getting lutetium edotriotide versus standard of care everolimus and 10 milligrams daily. You will note that lutetium edotriotide is given once every 3 months for a total of 4 cycles. Now, this is the very first phase 3 clinical trial to compare PRT versus an approved targeted therapy option. So the COMPETE trial showed that lutetium edotriotide significantly improved progression-free survival versus everolimus. The median progression-free survival was 23.9 months with the lutetium edotriotide versus 14.1 months with everolimus, hazard ratio 0.67, meaning 33% reduction in the risk of progression or death. There was also an improvement in response rate, so 22% versus 4% with everolimus. If you look at subgroup analysis, whether it's GI versus pancreatic neuroendocrine tumors, whether it's grade 1 versus grade 2 tumors, whether you use this in a first line or second line setting, you can see that for grade 2 tumors and for use in a second line setting, lutetium edotriotide led to a significant improvement in the progression-free survival. For all the other subgroups, there was a numeric improvement in progression-free survival, but it did not reach statistical significance. If you look at side effects, this drug can cause general side effects such as fatigue and asthenia. It can cause GI side effects like nausea and diarrhea, and then it can cause low blood count, so everything as we expect for PRT. Of note, one patient out of 217 got myelodysplastic syndrome in the lutetium edotriotide arm. So So where does lutetium edotriotide fit in our clinical practice? So I'm showing you head-to-head data for lutetium dotatate and lutetium edotriotide. So lutetium dotatate was evaluated in another one study where the control arm was high-dose octreotide, whereas lutetium edotriotide was evaluated in the COMPETE study with a control arm of everolimus. The patient population for lutetium dotatate was grade 1 and grade 2 midgut neuroendocrine tumors, whereas that for lutetium edotriotide is grade 1 and grade 2 GI and pancreatic neuroendocrine tumors. The lutetium dotatate study was only for second-line treatment, so progressed on prior somatostatin analog. The lutetium edotriotide study included 15% of patients getting it in the first-line setting. In terms of efficacy, so lutetium dotatate showed a median progression-free survival of 28.4 months, response rate 18%, and there was an almost 12-month improvement in overall survival, though it was not statistically significant. And lutetium edotriotide led to median progression-free survival 23.9 months, response rate 22%, and we don't have data for overall survival just yet. In terms of toxicity, so grade 3 toxicity, lutetium dotatate led to hematologic toxicities grade 3 of 3% and then 1% renal toxicities. We don't have this data yet for lutetium edotriotide. And then in terms of bone marrow toxicity, development of myelodysplastic syndrome or MDS, that was 2% with lutetium dotatate, 1% with lutetium edotriotide. So as you can see, both lutetium dotatate and lutetium edotriotide have favorable efficacy and safety profile over the respective control groups. Can't necessarily say that one is better than the other, but I think both will have their role in our clinical practice. But what the COMPETE trial really informs us is on treatment sequencing, that we should really use PRRT before targeted therapy and specifically before everolimus. There's also treatment schedule consideration. So lutetium edotriotide is given once every 3 months, whereas lutetium dotatate is given once every 2 months. And finally, we are awaiting data for lutetium edotriotide for the more aggressive grade 2 and grade 3 GI and pancreatic NET population, Ki67 up to 55%. This is being evaluated in the COMPOSE study, so results coming soon. What about PRT combination strategies? There's many combination strategies in clinical trials out there. I'm going to highlight one that is particularly exciting this year. So this is targeting the estrogen receptor alpha or ESR1. This is work done by my colleague, Dr. Xavier Koiken, in his lab with pancreatic neuroendocrine tumor cell lines that showed that blocking estrogen receptor alpha or ESR1 with the breast cancer drug called fulvestrant and giving that in combination with PRRT with lutetium dotatate can actually make these pancreatic neuroendocrine tumor cells more sensitive to the radiation. And using this as a basis, we designed a phase 1 study of fulvestrant plus standard lutetium dotatate PRRT for pancreatic neuroendocrine tumor patients. This is a small pilot study. This particular combination, you can see that the PRRT is given per standard of care. So it's lutetium dotatate given once every 8 weeks for 4 cycles. And fulvestrant is a shot. It's an injection given once every 4 weeks for a total of 8 months. With the exception of the first month, you get 2 injections. So this trial is currently enrolling at the University of Chicago. And a few weeks ago at ESMO GI, we're excited to share the exciting preliminary results of this study. For the first 6 patients that we treated, you can see that the response rate with fulvestrant plus PRRT is 50% in our study. Shown here are representative before and after MRIs for a patient who responded. You can see that on the top here, the liver lesion seems to have disappeared, and then on the bottom here, that liver lesion seems to have significantly reduced in size. This seems to be very well tolerated. Most adverse reactions are grade 1. There were no grade 3 or higher adverse reactions. The most common side effects include fatigue, flushing, nausea, vomiting, diarrhea, and low blood counts. So what's new with alpha PRRT? Alpha PRRT is the next generation form of PRRT using lead and actinium, which are alpha particles, as opposed to lutetium, which is beta particle. And alpha particles have a higher linear energy transfer, but also a shorter range, so theoretically more effective cell kill while sparing the surrounding healthy tissue. Well, how does this translate into clinical trial results? Shown here are results from a clinical trial for lead VMT alpha net. So this is a phase 1 study that is currently ongoing that showed an encouraging response rate of 43%. You can see before and after CT scans for a patient who is responding here. This drug tends to be very well tolerated. There have been no dose-limiting toxicities or any grade 4 or 5 toxicities so far in this study. The most common side effects are nausea, hair loss, fatigue, diarrhea, and decreased blood counts. One of the considerations for alpha PRT is its effect on the kidneys. So shown here is the blood creatinine trend. So creatinine is a surrogate measure of kidney function. This drug generally causes grade 1 elevation in creatinine. Of the 10 patients reported with grade 1 creatinine elevation, 4 of them have recovered and 6 of them are still ongoing. This is another alpha PRT drug called lead-dotamtate. So shown here are results for the phase 2 Alpha Medic 02 clinical trial with 35 patients. The response rate for this drug in PRT naive patients is 60%, and the 36-month progression-free survival rate was 72%. You can see before and after PET scans of patients who responded very well to this drug. But what are the toxicities for this drug? For unclear reasons, almost half of these patients get dysphagia, which is difficulty swallowing, including 3% grade 3 dysphagia. And 37% of patients have some kind of renal event, including chronic kidney disease, increased blood creatinine, and decreased GFR. No patients in this study developed myelodysplastic syndrome or acute leukemia. A different cohort of the same study looked at lead-dotamtate for use following progression on previous PRT. So for example, if they got standard lutetium dotatate and progressed, they could go on this cohort of the study to see how alpha medics works. And so this drug is effective after previous PRT, so it showed a response rate of almost 35% and an 18-month progression-free survival of 83%, shown here before and after PET scans of a patient who responded very well to lead-dotamtate following progression on prior lutetium-based PRT. What about the actinium-based drug? So this is RYZ101, so actinium dotatate. Shown here are the phase 1b portion results of the ongoing Action 1 study. So this study showed the preliminary response rate of 29% in pretreated neuroendocrine tumor patients. In terms of safety, 9 out of 17 patients, so 53% of patients, had a grade 3 or higher adverse reaction, including one patient who had a fatal adverse reaction. These grade 3 adverse reactions included anemia, low lymphocyte count, decreased creatinine clearance, and decreased weight. The phase 3 portion of the Action 1 study is ongoing and we're awaiting the results. So this portion of the study will enroll patients with GI and pancreatic neuroendocrine tumors who have progressed on prior lutetium-based PRT, randomized 1-to-1 to getting RYZ101 versus the investigator's choice standard of care treatment, which includes everolimus or sunitinib or SSAs. And lastly, this is a newer alpha particle PRT called RYZ401. So this is actinium RYZ SSA1. So this is a next generation PRT treatment engineered to improve renal clearance and also tumor retention. So this eliminates the need for using amino acids during treatment. So the phase 1 trial for this drug is currently enrolling. We're going to switch gears now to talk about novel targeted and immunotherapies for neuroendocrine tumors, starting with somatostatin receptor, SSTR. So this is an old target, but we'll talk about some of the new treatments coming. So the SSTR2 is the target for somatostatin analogs such as octreotide and lanreotide, and also for PRRT. But we'll show you data today for new SSTR agonists, for SSTR antibody drug conjugates, and there's also preclinical data for bispecific T-cell engagers and cellular therapy, including CAR T therapy targeting SSTR. So hopefully these will make it to clinical trials soon. So starting with new SSA, so this is CAM 2029. This is a new octreotide subcutaneous depot for self-injection. As you can see in the picture here, it comes in a pen, so the patient can inject themselves with this SSA at home. This is done once every 2 weeks. And this is being studied in the phase 3 Sorrento trial, which will compare CAM 2029 versus standard of care octreotide LAR or lanreotide. And the purpose of this is to look at how effective CAM 2029 is at tumor control. So the primary endpoint is progression-free survival. This study has completed accrual, and we're waiting for the results to be released soon. Paltusotine is an oral SSA, so SSA that comes in a pill, and this is being studied for control of carcinoid syndrome. Shown on the left-hand side are results from a phase 2 clinical trial that showed that paltusotine reduced the median number of bowel movements and also improved flushing frequency. And so based on this is being further studied in the phase 3 CareFinder trial, which will randomize patients to getting paltusotine versus placebo. This is an ongoing clinical trial. And what about using SSTR2 delivered other drugs? So this is what's called antibody drug conjugates, or specifically, this is a non-peptide drug conjugate, where the drug called CRN09682 targets and binds to the somatostatin receptor, gets internalized by the cell, and then releases its cytotoxic payload from within the cell. In this case, the cytotoxic payload is MMAE, which is a chemotherapy agent. So this is kind of like a Trojan horse that recognizes and uses the somatostatin receptor to get into the cells and releases chemo from within the cells. This is an ongoing clinical trial looking at pancreatic but also extrapancreatic neuroendocrine tumors, but also for neuroendocrine carcinomas. Another key target for GI and pancreatic neuroendocrine tumors is the VEGF pathway, so the vascular endothelial growth factor. You can see here drugs that have made it through at least phase 2 clinical trials for neuroendocrine tumors, of which sunitinib is approved for pancreatic neuroendocrine tumors and cabozantinib is approved for both pancreatic and extrapancreatic neuroendocrine tumors. The newest kid on the block is zanzalintinib. So this is a next generation VEGF receptor targeting tyrosine kinase inhibitor. In addition to VEGF receptor, it also targets TAM and MET and other kinases. So this blocks tumor invasion and metastases. Zanzalintinib is being studied in a phase 2 and 3 clinical trial called the Stellar 311 trial, which will take patients with advanced neuroendocrine tumors progressed on at least one prior line of therapy, randomized 1-to-1 to getting zanzalintinib versus everolimus as the control group. And patients who are randomized to everolimus can cross over to zanzalintinib upon disease progression. So this is currently enrolling. Belzutifan is another targeted therapy option. So belzutifan targets the hypoxia-inducible factor HIF2 alpha. HIF2 alpha is implicated in patients who have von Hippel-Lindau disease. And so for patients who have von Hippel-Lindau disease and develop a pancreatic neuroendocrine tumor in that setting, this drug can be very effective. Shown here are the results from the phase 2 study evaluating belzutifan for VHL-associated pancreatic neuroendocrine tumors, which showed an impressive response rate of 91%, including 32% of patients who got complete responses. So this is actually an FDA-approved treatment option for those patients. What about for the general pancreatic neuroendocrine tumor population? So shown here is a different study looking at belzutifan for PNETs in general, and the response rate was only 10% with a median progression-free survival of 3.9 months. And even within the responders, you can see that 2 of them actually had VHL. So overall, for the general PNET population, doesn't seem to work as well. And last but not least, where are we with immunotherapy and specifically CAR T therapy? So CAR T therapy is a type of immunotherapy where we harvest the patient's T cells or fighter cells of the immune system, engineer the T cells to recognize a marker on the tumors, and then reinfuse them back to the patient. CHM 2101 is the very first CAR T therapy developed for neuroendocrine tumors. And we recently learned of the initial study results at our ASCO meeting. So this shown here are the patients who are treated so far, which included 4 neuroendocrine tumor patients. You can see that the best response that these patients got was stable disease, and the progression-free survival seems to range around 5 to 6 months. But of course, we'll have to wait for more mature data for this study. This remains very, very exciting in our field. So as you can see, there are a lot of exciting and new developments for the treatment of neuroendocrine tumors this year. And none of this would have been possible without clinical trials. So we highly, highly encourage our patients to consider participating in clinical trials. And I want to end my talk on some practical guidance for our patients for clinical trials. So what are clinical trials? So clinical trials are studies of new treatments. So this can be a brand new drug or it can be a new treatment strategy. For example, using CAPE-10 as a preventative strategy after surgery for localized pancreatic neuroendocrine tumors. It can be a drug approved for another indication that we're testing it in neuroendocrine tumors, or it can be combining a new drug to an existing standard of care, such as the PRT combination trials. Clinical trials come in three phases. So phase 1 clinical trials are studying new drugs or combinations really to test for safety, understand what the side effects are, and to find the right dose. Phase 2 trials are testing for preliminary efficacy, and phase 3 trials are those that have made it through phase 1 and phase 2, and now they're being compared against the standard of care treatment. Now, do all clinical trials have a placebo arm? This is a commonly asked question by my patients. Turns out no. So where we generally see placebo arms are phase 3 clinical trials. Remember, these are comparing study drug versus standard care treatment. And where we see placebo arms in these settings is for patients who have no standard care treatment options left, meaning they have exhausted all standard care treatments. Therefore, it's ethical to have a placebo arm built into that kind of study. But otherwise, phase 1 and phase 2 clinical trials generally do not have placebo arms. So what are the benefits of participating in a clinical trial? Well, this is a way to get access to a potentially new treatment that you wouldn't otherwise get standard of care. And these treatments may be more effective and or safer than the standard treatment. Remember that all successful and FDA-approved treatments for neuroendocrine tumors such as lanreotide and PRT and cabozantinib, they all started as clinical trials. So you could help yourself, but also help other neuroendocrine tumor patients like you by participating in a clinical trial. Now, what are the risks of going on a clinical trial? Well, all successful treatments came from a clinical trial, but not all clinical trials are successful. So what if the study treatment is not as effective as a standard treatment? Or what if it's more toxic? When is the right time to participate in a clinical trial? Well, many patients think that, oh, I still have standard treatments left, so now is not the right time. But turns out that's not true. In reality, clinical trials exist for all phases of the treatment journey. For newly diagnosed patients, for patients who've been on a few treatments but still have many treatment options left, and also for patients who have exhausted all standard treatment options. So we should really consider clinical trials for every phase in the treatment journey. So how do I find a clinical trial suited for me? Well, this is hard. Even oncologists who specialize in neuroendocrine tumors can't possibly tell you every single trial out there in the field. So this is why the Neuroendocrine Tumor Research Foundation developed this clinical trial finder on their website, netrf.org. You can see here that you can enter your geographic location, you answer a brief survey about your tumor, what treatments you've had, and then it will spit out a list of potential clinical trial matches as shown here on the right-hand side of the slide. And this is super helpful. And of course, this list doesn't mean that you will automatically qualify for the trial or that the trial will have slots available. It is still best to consult with the study team who is running the trial to understand if it suits you or not. But this is a great starting point to narrow down the list of trials to produce the best matches so that you can talk to your doctor more about. So I hope you all find this very helpful. And that concludes our talk today. Thank you very much for joining us.
Our next speaker is Dr. Anna Green, NETRF's Chief Scientific Officer. She leads our research programs and helps build the scientific community in the search for better treatments and cures. Dr. Green has a PhD from Dartmouth College. She'll talk about NETRF's research priorities and advances in research, the future of neuroendocrine cancer care.
Hi, I am Anna Green, the Chief Scientific Officer at the Neuroendocrine Tumor Research Foundation. Over the next 20 minutes, I want to do something hopeful. I want to show you where neuroendocrine cancer research stands and where it's going. So whether you were diagnosed last month or have lived with this for years, this talk is about your future. So let me first tell you what I hope that you'll walk away with. So if you remember nothing else, I want you to leave with 3 things. 1, what has changed, that outcomes have improved, and today's care reflects decades of advances. 2, where we're going. NetRF is focused on earlier detection, better treatments, and more precise care. And 3, how you shape it, because patient data and patient priorities help decide which questions matter most. And that's today's story, what we've learned, what we're funding, and what you can help make possible. And this year, you told us directly what matters. So this year's Know Your Net survey was our largest ever, with more than 1,100 responses from newly diagnosed patients to individuals who have lived with this disease for 16 years or more. And 5 priorities rose to the top: treatment access and sequencing, earlier diagnosis, subtype-specific needs, clinical trials access, and quality of life. And these aren't a wish list that we're reacting to. These map directly onto the agenda that NetRF leads, and your voice confirms that direction. So let's start with what's actually changed. Over the past 2 decades, outcomes for people with neuroendocrine tumors have improved substantially. 3-year survival has gone from about half of patients to roughly 85%. And that reflects real advances in how this disease has been recognized, imaged, classified, and treated. And for the longtime patients listening, the science behind your care today did not exist when many of you were diagnosed. And this is the promise of research, and we're not standing still. So what makes sure that this progress keeps coming? So NetRF exists to make sure this research keeps moving. Our vision is a world where neuroendocrine cancers are both understood and curable. Since 2005, we've invested more than $40 million in research, funded 81 institutions, and reached 17 countries. For patients, that means someone is in your corner every day working to fund the research that builds your future. But to understand the research, we need to understand the disease. Here's something important to understand. Neuroendocrine cancer is not one disease. Neuroendocrine cells live in organs throughout your body, so these tumors can arise almost anywhere, such as the small intestine, the pancreas, the lungs, stomach, and other sites too. And where a tumor starts shapes how it behaves, how it's monitored, and which treatments make sense, which is exactly why a one-size-fits-all approach doesn't work. Even within neuroendocrine cancer, tumors differ in 3 big ways. First, where they start. Second, how they grow, such as things like grade, Ki67, and differentiation. And third, their underlying biology, like inherited syndromes, molecular drivers, and their immune environment. So the goal isn't just more research, it's research matched to the biology patients actually have. There's one distinction worth pausing on. You'll hear 2 terms a lot. NETs, or neuroendocrine tumors, are well differentiated, lower grade, and generally slower growing. Sometimes they can be considered a chronic disease. NECs, or neuroendocrine carcinomas, are poorly differentiated. They're always high grade, faster growing, and they need their own research strategy. So these come from the same family of cells, but very different diseases, and NetRF research spans the whole range. So why does focused, dedicated research funding matter so much right now? This disease has been historically underfunded and understudied. Many treatments slow it rather than cure it, and despite rising incidence, it receives far less funding than many other types of cancers. So when funding is uncertain, we don't stop. NetRF keeps promising discoveries moving forward. But we don't just fund the research, we help shape it too. Beyond funding, we help set a shared direction for the field, so effort goes where patients need it most. We have a board-approved research roadmap, and this year, a dedicated funding call for early detection research. We have an expert board of scientific advisors whose guidance shapes the priorities we set, and a commitment to fund neuroendocrine carcinomas alongside neuroendocrine tumors, making sure that high-grade disease gets the attention it deserves. Here's how funding reaches the lab. We fund research at every level: big team science, individual investigators, high-risk early ideas, cross-disciplinary work, and the next generation of neuroendocrine cancer researchers. Each mechanism does a different job: de-risking new ideas, supporting rigorous science, and keeping talent in this field. All of it points at 3 priorities. In 2025, we adopted our research roadmap, which is a strategic guide to how NetRF invests in strategic research. Our roadmap consists of 3 priorities, and each answers a question that you all live with. Early detection starts with, why did it take so long to diagnose me? This pillar is about shortening the path to diagnosis and catching the disease before it spreads. Better treatments. This starts with, will there be more than just stabilizing my disease? This is about creating more durable, more tolerable options that actually change outcomes. And precision medicine. This asks, why is my disease so different from someone else's? This is about matching care to your tumor's biology instead of treating everyone the same way. So what does this mean for you today and tomorrow? Here's an honest bridge from now to next. Today, there are more treatment options than 20 years ago. We have better imaging, more clinical trials, and disease control is possible for many. What comes next is better treatment sequencing, earlier detection, biomarker-guided trials, and durable control and cures. The future isn't one breakthrough. It's a sequence of advances that make care earlier, smarter, and more effective. Let me show you the engine behind that. The next era isn't only new drugs. It's a smarter system. Find the disease earlier, classify it more precisely, treat it more intelligently, and learn from every patient through registries, biobanks, and trials. That aim is simple: the right patient, the right test, the right treatment, all at the right time. So let me make that concrete with 4 frontiers that we're funding. Frontier 1 is finding the disease sooner. Too many patients spend years misdiagnosed, or the disease is found only after it's spread. Right now, NetRF-funded teams are developing blood tests that could catch this earlier, including work using tiny particles called extracellular vesicles that tumors shed into the blood, a simple blood draw that could flag the disease sooner. If we catch it, we want to treat it better. Frontier 2 is smarter radiation. Radioligand therapy, like PRRT, is becoming a platform, not a single therapy. Researchers are testing more powerful payloads, alpha emitters like actinium-225 and lead-212, new targets, and new combinations. The goal isn't just stronger radiation, it's radiation delivered more intelligently. And this is NetRF-funded work. Our teams are building the pieces that make these next-generation treatments possible, finding ways to deliver powerful alpha emitters safely and precisely to tumor cells. Beyond radiation, treatments are getting more precise. Frontier 3 is precision treatment, moving from what's available to what best fits this tumor. That means better sequencing, targeted drugs, and early cell therapies. And here's a story that I love. CDH17 CAR T-cell therapy started in a NetRF-funded lab, and it's now in its first human clinical trial for intestinal nets. That's the whole point of what we do. Research we funded at the bench is now reaching patients, and for the most aggressive disease, there's a whole new landscape. Unlike NECs or neuroendocrine carcinomas need their own research strategy. The most forward-looking work is shifting from broad chemotherapy toward biomarker-guided targeting, smart-guided antibodies, immune engagement, and hitting more than one target at once. This is promising, but it's still early and trial-driven. And this matters most to patients who have had the fewest options. NetRF funds research aimed squarely at neuroendocrine carcinomas, defining its subtypes, finding targets unique to these tumors, such as DLL3 or SEZ6, and studying the cells that survive treatment and drive relapse. But none of this happens without you. The next era of research needs your voice, your data, your questions. Make the invisible visible by reporting your symptoms and quality of life. Ask about clinical trials, registries, and tissue studies. Push your team on how your tumor's biology shapes your care. And keep us accountable too. Tell NetRF what matters the most. Research moves faster when patients aren't just participants, but also partners in deciding what progress looks like. We've committed $25 million to neuroendocrine cancer research by 2030, and we'll keep funding until neuroendocrine cancer is understood, treatable, and curable. Thank you for being here and for being part of this. This work moves forward because of you, so please don't hesitate to reach out. My email address is on the screen, and I would love to hear from you. Thank you for your time and your attention.
Dr. Yuhavir Grewal is a medical oncologist specializing in GI and neuroendocrine tumors at Emory University's Winship Cancer Institute. His research focuses on drug development and care delivery innovations for NET patients. He joins us now to discuss what happens after your diagnosis, monitoring, surveillance, and ongoing care.
Hello, everyone. I am Uday Grewal. I am a GI and neuroendocrine medical oncologist at the Winship Cancer Institute of Emory University in Atlanta, Georgia. I will be talking about what happens after your diagnosis, which includes monitoring, surveillance, and ongoing care. So, assuming this talk really comes after you've learned a little bit about the diagnosis of neuroendocrine tumors, I still wanted to take some time to discuss two core concepts that pertain to the diagnosis of neuroendocrine cancers. So, when you get access to a pathology report that tells you what exactly your diagnosis is, two things that should stand out are grade and differentiation. So when a pathologist looks at a slide from a biopsy specimen, which is how we diagnose neuroendocrine tumors or neuroendocrine carcinomas, they will assign a grade to the cancer, which basically is derived from something called Ki67 that tells you how rapidly the cancer cells are proliferating or dividing when looked at under the microscope. So the higher the Ki67, the more rapidly the cells are proliferating or dividing, and the more aggressive the cancer is. So grade 1 may be Ki67 less than 3%, 3 to 20 is grade 2, and more than 20% is grade 3. Similarly, differentiation tells you when a pathologist looks at the slide under the microscope, do the elements in that tumor look nicely put together and packed together nicely? If they are, then that's well differentiated, and those tumors are more well-behaved tumors. Poorly differentiated cancers or neuroendocrine carcinomas sort of have a haphazard arrangement when looked at under the microscope. So grade and differentiation are two key core concepts that you should be looking at or should be familiar with when you are first diagnosed with a neuroendocrine tumor. So your cancer diagnosis may be neuroendocrine tumor of the pancreas, WHO grade 1, well differentiated. After you've had a diagnosis, the next big thing that we think about is determining the stage of the cancer. And what does that mean? So after you've had a diagnosis, we want to see if the cancer came from the small bowel or the pancreas or the lung, how far has it traveled in the body, which really is important to determine what kind of strategies can we explore or use to treat your cancer. So two big types of scans that patients will undergo are CT scan or MRI. Most commonly, it is a CT scan. So before we talk about how we determine the stage after we looked at the cancer on a CT scan, it's important for us to know that a CT scan in isolation will really not tell us much. A CT scan gives you all of the information that you need in the case of a neuroendocrine tumor diagnosis, is only made possible through the dyes that we use along with the CT scan and how we take pictures after your body has been injected with that dye. So in the image below here, there is a pink circle that highlights a cancer spot within the liver. This was not visible in a portal venous phase where we did not take a picture as that contrast was traveling through the arteries. So the point I want to highlight here is we really need a contrast enhanced CT, and we need the pictures to be taken at the appropriate time for us to see all of the cancer spots that are present in, for example, the liver in this case. Those spots can be missed if the contrast is not there or the contrast images are not appropriately timed. This is not uncommon scenario in clinical practice. We often see patients who are referred to our clinic and they walk in with the assumption that their cancer is only limited to the small bowel or the pancreas. And when they get the appropriate imaging done, we see some spots in the liver or beyond because previously they did not get the appropriate imaging. Similarly, MRI is another imaging modality that is among the first scans that you will receive when you first get diagnosed with a neuroendocrine tumor or neuroendocrine carcinoma. And MRI tends to be the preferred scan for determining the burden of the cancer in the liver or getting better images of the liver to determine where all the cancer has spread. Even with the MRI, an MRI in isolation will not give you all of the information that you need. The images will not be as clean and nice as they would be if the MRI is done with a specialized dye called EOVIST. As you can see in these images, the EOVIST dye really helps bring out these spots nicely, the spots that have cancer, and the bright background is normal liver. So I always encourage all of my patients to get MRI scans done with EOVIST. That really helps us determine the burden of the cancer in the liver, and then use the right treatment strategy or right treatment modality that would be appropriate for the burden of disease. And liver is the most common site of metastases for neuroendocrine cancer. So using the right imaging modality to determine the presence or absence of disease in the liver is really vital. In addition to CT and MRI scans, we now have this amazing tool called PET scans, to be specific, somatostatin receptor PET scans that have come out of years and years of research. And they've really been game changers because they've allowed us to see more cancer than we were previously able to. About 70 to 80% tumors that are well differentiated express somatostatin receptors, and those cancers can be readily identified on these PET scans. And these are very specific, especially when it comes to determining the spread of the cancer to the bones. We know that neuroendocrine cancers love to go to the bones. MRI and CT scans can be helpful, but PET scans are significantly superior in terms of determining the spread of the cancer to the bones in patients with neuroendocrine cancers. There are two different types of somatostatin receptor PET scans that are commercially available, copper-based and gallium-based. And I often tell my patients there is practically no difference between those two scans, and we use them interchangeably in our practice. All patients with a neuroendocrine tumor diagnosis should be considered for a PET scan, at least at the time of diagnosis. And subsequent scans can be done based on two factors. Sometimes we want to do a PET scan because we know that at baseline, when we did a PET scan, there was a lot of cancer that had spread to the bone. So we want to see how that part of the cancer is doing. So we may get a PET scan a year later or 2 years later after the patient's been on some form of therapy. The other important purpose that these PET scans serve is they help us identify patients who will benefit from therapies that target somatostatin receptors. And those are somatostatin analogs or peptide receptor radionuclide therapy or PRRT, which is commercially available as Lutathera. And also a number of newer therapies that are being studied in clinical trials that target somatostatin receptors. So PET scans not only help us identify the extent of the cancer that is spread in the body, but also help us identify whether these cancers can be treated with specialized therapies that target somatostatin receptors. Now, the question arises, we have these scans, CT scans, MRI scans, and then PET scans, but how often should we be really getting these scans? So the answer really depends on, are you being treated with something, or are we really just following the cancer or observing the cancer or just doing scans to detect the recurrence of cancer? So in patients that are diagnosed early, so early stage neuroendocrine tumors, say in the pancreas or small bowel or in the lung, and if they have been treated with surgical resection to the point that they have been practically cured of the cancer at that point, we do scans after the surgery to detect the recurrence of the cancer. What's really important to highlight is a lot of the other more aggressive cancers, such as adenocarcinoma coming from the pancreas or colon, et cetera, those cancers, the risk of recurrence is particularly high in the first 2 to 3 years after surgery. So we tend to do more scans for the first 2 years and then slow down a little bit in the third year and stop at 5 years, because the cancer has really not come back in the first 5 years. It's unlikely that it will come back after 5 years of surgery. But neuroendocrine tumors are a little different in the sense that they're relatively slower growing cancers, so they don't really behave the same rules as other cancers. So, as you can see in this image, the risk of recurrence is very, very low in the first 5 years after surgery, but it starts going up after 5 years. How often we should be doing these scans, there's some guidelines that help us, but the rule is, as long as you're getting some form of imaging like CT scan or MRI, and you're not stopping at 5 years, you're really making a difference to the patient's life. So we try to get some scans, obviously, after surgery to see how the surgery went and to let the cancer sort of declare itself. But I educate my patients that if we're going to perform surveillance scans, we have to at least go for 10 years, because the risk of the cancer coming back really starts rising after 5 years. And in patients that are just being followed to assess for recurrence of the cancer, we prefer MRI scans over CT scans if possible, because CT scans have an added risk of radiation exposure, which is not true for MRI scans. In patients with stage 4 cancer, where we are treating the patient's cancer with some form of therapy, the cadence of the scans could be every 2 to 3 months or sooner if there is concern that the cancer is progressing. Now, after we've determined we have a diagnosis, we have staging done with CT or MRI and a PET scan, the next thing that we're looking at is what kind of blood test should the patient have. Now, there are two key types of blood tests that you will receive, especially at your initial visit with your medical oncologist or surgeon. These are either hormone-based tests or non-hormone-based tests. So there are many patients with neuroendocrine cancers that produce an abnormally high amount of a particular hormone. For example, in small bowel neuroendocrine tumors, it could be serotonin, and in some rare situations in pancreatic neuroendocrine tumors, it could be other hormones like gastrin, VIP, or glucagon. So testing for these based on the symptoms is really essential to sort of determine, at least have some evidence that these excess hormones are being produced, and then follow them over the course of the treatment, eventually to see how they're going up or down, or basically changing in levels as patient's cancer is being treated with a particular therapy. There are also other tests that you may come across. There are like chromogranin A and pancreastatin. These are tumor markers that have sort of fallen out of favor in the last few years, because there's data showing that they really don't add much to the care of patients with neuroendocrine cancers. There are also newer tests like NET tests that are currently being investigated but are not ready for clinical practice. There are other parameters that we can look at, such as NT-proBNP, and I will talk about carcinoid heart disease in a little bit, that is a condition that affects your heart in patients with carcinoid syndrome. But these are some of the key tests that are relevant to patients with neuroendocrine cancers. In addition to these tests, you may receive the more regular tests, such as complete blood cell count or comprehensive metabolic panel that includes liver function, kidney function, and electrolytes, etc. Now, in patients with carcinoid syndrome, which results from excess production of serotonin, usually comes from small bowel neuroendocrine tumors that have spread to the liver and beyond, and some of the symptoms that we see in those patients are flushing, diarrhea, wheezing, etc. Long-standing exposure to an excess production of serotonin in the body can lead to some scar tissue formation in the heart. And this can destroy the valves that are important for ensuring forward flow of the blood. So the blood can start backing up and affecting your cardiac function or heart function, and also affecting your breathing, etc. So this is really important to screen for, because a lot of the patients may not develop any symptoms until it becomes more severe, heart failure. So all patients that have symptoms associated with carcinoid syndrome or have elevated levels of serotonin especially are screened for carcinoid heart disease. But in my practice, I actually screen all of my patients with newly diagnosed small bowel neuroendocrine tumors that have spread to the liver or beyond, or even those patients that may have a lung neuroendocrine tumor that is spread outside of the lung, especially to the liver and beyond. And any patients with a neuroendocrine tumor that we don't know where it originated from, something we label as net of unknown origin, even those patients, I try to at least get a baseline echocardiogram, which is an ultrasound of the heart, to screen for any damage that might have occurred to the heart. This may be coupled with testing for hormones like serotonin, or also NT-proBNP, which sort of is a marker of stress on the heart, and if elevated, should raise suspicion for an underlying carcinoid heart disease. Now, in addition to some of this basic workup that we just talked about, scans, blood work, etc., we have been talking about molecular profiling, as you may be aware, in other cancers that has really become the standard of care and has really revolutionized cancer therapy, because we've been able to identify some molecular markers that can be used to determine the prognosis, or it can also be used to open doors for treatment options for our patients with cancer. But our field of neuroendocrine cancers has been a little slow in adopting this. And I call this a missing piece of the puzzle, because I think that molecular profiling really adds a lot of critical information and data to the diagnosis of patients with neuroendocrine tumors, and should actually be adopted in clinical practice. Now, what does molecular testing or molecular profiling really mean? It basically means testing your cancer for certain key genetic mutations or other alterations. And as I said, this could help inform the biology, as in it could help with prognosis determination. But in some situations, it may also help identify patients who may benefit from certain types of therapies after we've determined a targetable alteration in one of these tests. There are two key ways of performing molecular testing. One is a liquid biopsy, and the other is a tissue NGS, or tissue next generation sequencing. So basically, it's the same test. One is a simple blood draw. We extract some circulating tumor cells from your blood, and we run some molecular tests to identify mutations or other alterations. The other way of doing this is on the biopsy specimen, if there is tissue left, we send that for molecular testing, and that helps us identify some key mutations or alterations. The best yield is combining these two tests together, so we can capture everything at the same time. For example, the liquid biopsy may not capture everything, the tissue will capture what's left, and vice versa. So this is something that I have increasingly adopted in my practice, and I would encourage you to discuss with your oncologist as well if that has not already been done. Now, after we have all these information or data available, the next key step is to discuss your case at a multidisciplinary tumor board, to engage in multidisciplinary discussion. This is why it's really important for your case to be discussed or reviewed at a NET center, a multidisciplinary neuroendocrine tumor center, a specialized clinic that has all the specialties that you would want to sort of opine on your case, because no decision that we can make for the management of neuroendocrine cancers can be made in isolation. So it's not just medical oncology, it's also surgical oncology and radiation oncology, nuclear medicine, interventional radiology, pathology, radiology. We need input from all of these specialists at every step of the way, especially when we're trying to determine whether one treatment is better than the other. So engaging all of these specialists at the same time really helps us tailor care plan to your specific case. As you may have heard everywhere, no two patients with the same neuroendocrine tumor diagnosis will have the same journey and will have the same cancer. I cannot overemphasize the importance of multidisciplinary discussion. Often specialized net centers have very sophisticated mechanisms for multidisciplinary tumor board discussions. And I want to give a shout out to to other specialists who form such an important part of this multidisciplinary care team, such as nurses, registered dietitians, pharmacists, clinical research coordinators, licensed geneticists, who fill such important care gaps that our patients with neuroendocrine cancers sort of experience and provide them the care that they need through these specialized services. So after your cancer diagnosis and including your pathology slides, your images and other molecular data, lab data has been collected, it is brought to a multidisciplinary tumor board, and we engage all of the specialists in discussions around what is the next best step for treating a patient with neuroendocrine tumor. So there are a host of different therapies, and I often talk about the NET wheel with my patients. This is specific to patients with well-differentiated neuroendocrine cancers. There's a lot of different therapies that we can choose from, PRRT, somatostatin analogs, targeted therapies, chemotherapy, local regional therapy, surgery, and surgery not just for patients diagnosed with early stage disease, but also with metastatic disease. So engaging all of the relevant specialties to determine what should be the best next step in treating your cancer is really, really important. But as you can see at the very center of this wheel is clinical trials. And I very strategically placed clinical trials over there is because that center of the wheel sort of helps move the wheel and keep all the spokes moving. So all the progress that we are seeing today in our field and will see in the future is driven by clinical trials. And I very much consider clinical trials to be a part of the standard of care in patients with neuroendocrine tumors and even other cancers. So I would encourage you to discuss with your treating oncologist or surgeon or any other specialist who you are working with to consider you for enrolling onto a clinical trial. You could take the lead and go on to clinicaltrials.gov and look at available clinical trials. All you need is just plugging in neuroendocrine cancer and your location or preferred location, and you will be able to look at a host of different clinical trials that are ongoing and might be a fit for you. But the other way of doing that, which I think is perhaps a better way of doing that, where you can get more support, is engaging with advocacy organizations like NetRF. They have a special page for clinical trials for neuroendocrine tumors. You can also engage with patient advocates to help you identify some clinical trials that you might benefit from, and seriously consider that as a part of the standard of care for treating your cancer. So as you can see, there are a lot of standard options that are available today for treating patients with neuroendocrine cancers, and multidisciplinary care is at the very core of providing patients with personalized care that is tailored to their specific case, to their specific diagnosis. And clinical trials have increasingly become a very relevant and critical component of the standard of care for treating patients with neuroendocrine cancers. I hope you found this talk helpful and useful.
Dr. Thor Halfdan is a professor of oncology at Mayo Clinic, where he specializes in neuroendocrine cancer and cancers of unknown primary. He's the co-chair of the Pancreatic Neuroendocrine Tumor Board at Mayo, active in research, and a president emeritus of NANETS. Dr. Halfdan will speak on understanding the long-term impact of treatment.
Hello, my name is Thor Halfdan. I'm a medical oncologist specializing in the care of patients with neuroendocrine tumors at Mayo Clinic in Rochester, Minnesota. I will be discussing the long-term impact of treatment for neuroendocrine tumors in the next 20 minutes or so. Here I have my disclosures. Thought we would start with a little bit of a review of the epidemiology of neuroendocrine tumors. So how common are they? Why are we even talking about this? And we're talking about this because these are not uncommon tumors. And they are getting more common. So there's about 5-fold increase in the number of new cases since the mid-70s. A lot of that is from well-differentiated and localized tumors. And we're diagnosing more and more patients incidentally, so they don't have symptoms. We just find this on scans because patients go and have scans for other reasons. And I just wanted to point out a few of them. You can see those lines going back to 1975 up to 2020. This is a relatively recent paper that was published last year. You see there has been a substantial increase in lung neuron tumors. They are at the top there. And then if you look at pancreas, we're definitely seeing a lot more of pancreas, small bowel or small intestinal neuron tumor, and appendix neuron tumors. So all of them seem to be getting more common. And I'm not sure if they truly are getting more common. It's just that we're getting better at diagnosing them. So what does this really mean? So this means that with more diagnosis of neuron tumors, we have more patients to take care of. And also, not shown on this slide, is that the prognosis or the life expectancy, or what we call overall survival or OS, has improved over time. So if we keep diagnosing more and more patients and the life expectancy is getting better at the same time, that means that we're going to have more and more patients living with a diagnosis of active neuron tumor or with a history of having had a neuron tumor that was successfully treated, so survivors of having neuron tumors. And you can see on this slide there, this is what's called the prevalence. So this is the number of patients actually living with neuron tumors going back to 2001. You can see that it has increased substantially. And on the bottom graph there with the multiple colored lines, you can see the increase in the prevalence for the different types of neuron tumors over time. So this is rather striking. So one would wonder, is this unique to the US? And it turns out it's not. So these are data from Norway, obviously a much smaller population. We see the same. So this is the prevalence of small bowel, appendix, lung, pancreas, and rectum. The rectal neuron tumors, they are being seen more and more because we're doing so many screening colonoscopies for colon cancer, and we just happen to find them. So according to one study from the UK, they concluded that the neuron tumors are now possibly the 10th most prevalent malignancy and the second most prevalent intestinal or abdominal cancer following colorectal cancer. So that's not trivial. So the take-home message here is that we have rising incidence, so meaning more and more diagnoses per year. We have improving survival, which means rising prevalence, or the number of patients who either are dealing actively with neuron tumors or have had a neuron tumor in the past that was removed. And this will also translate to more and more patients needing treatment. So we have to be mindful of the side effects of such treatment over a long time. And that's what makes neuron tumor patients so unusual, is that we're treating for a number of years, sometimes even for decades. So there's long life expectancy, even in patients with very advanced disease. So we have a long time to develop side effects. So, and there are many survivors. So if you look at the surgical therapy for localized neuron tumors in the pancreas or the small bowel, that can be, the recurrence risk can be as high as 50% and can happen 10, 15, 20 years later after surgery. Many patients will not have recurrence, but may still suffer some complications from the surgical therapy that we need to be aware of. And some patients with very low risk surgical removed neuron tumors, such as certain type of lung neuron tumors or small bowel neuron tumors, are so unlikely to have the tumors come back that one wonders, should we even be following them and exposing them to the risk of radiation from scans over decades? And those are questions that we haven't fully answered yet. And then many patients with advanced neuron tumors are expected to be on therapy for a long time. So these data are getting a little old. So this is to look at the overall survival of patients with advanced pancreatic and small bowel neuron tumors after the tumors grow on somatostatin analog therapy like octreotide and lanreotide. And this graph is meant to show you the life expectancy is beyond 10 years, actually close to 12 years for both. So, and this means that even after the tumors start growing on injections, you can still live a very long time. And that is a time that you are at risk of having side effects from treatment and from the tumor. And there's a very unique situation with the long-term therapy because we have to really carefully consider the tolerance over a long period of time and even what we call low-grade toxicities. So mild toxicities, if you have to live with it every day and it's persistent and builds up, this can really impair your quality of life and even lead to people just not wanting to take treatment any longer. But we're not recognizing low-grade toxicities as much as we should. So we should be asking about this, and you should be telling us, the providers, about this. We know that older patients have a higher risk of these side effects. And even after we stop the treatment, some of these side effects can linger for a long time, and even in some cases may not even go away ever. So low-grade side effects could be like tiredness, digestive problems like diarrhea, constipation, nausea, neuropathy with numbness and tingling, and skin toxicity, which can be visible to others as well and lead to considerable stress. And what I always tell my patients that if we expect that you will live a long time from a cancer standpoint, don't drop your primary care provider. We need to be mindful of all the other health maintenance stuff that we need to do. It's like taking your car in for the regular oil check. So you got to go in, have your blood pressure checked, your diabetes or blood sugars. Look for all of the things that the patients or individuals without neuroendocrine tumors do, because we don't want you to suffer the risks of having high blood pressure or undiagnosed diabetes. And so we've got to take care of all of that stuff. And then also cancer screening. If you have had surgery for a low-grade neuroendocrine tumor, you need to get your colonoscopy when that's supposed to happen, your breast imaging when that's supposed to happen, and all of those age-appropriate cancer screening procedures. So don't forget about that. And then the other important stuff that all of us should be doing is try to maintain as much as we can healthy weight and healthy diet, exercise regularly, and have a healthy sleep routine. Sleep is very important. So let's talk a little bit about the long-term effects of primary tumor resection and other treatments that we do. And I'm going to focus on diarrhea. This is my office, and this is as ChatGPT thinks my office looks like. And what I wanted to let you know that you have to talk about uncomfortable stuff in this office. So we talk about poop, we talk about bowel habits, and the things that you don't want to talk about. And the reason we do that is that a lot of people suffer from diarrhea, but a lot of people don't want to talk about diarrhea. It's a chronic symptom. We see it a lot, and it can often be very, very easily treated and diagnosed. And sometimes it actually is not the carcinoid syndrome. It's something else. So there are three main causes of diarrhea in patients with neuroendocrine tumors. It's the carcinoid syndrome diarrhea, which I'm going to say it's probably minority. Bile acid diarrhea, which is a huge problem, and then the pancreatic exocrine insufficiency from the injections of lanreotide and octreotide, and also from pancreatic surgery. So if we talk about the bile acid diarrhea, just a quick review of how the bile is being made. It's made in your liver. It trickles down into your small intestines, and then it blends in with the food. And then when it gets to the far end of the small intestine, it's reabsorbed, taken back up into the system, shuttled back to the liver, because the body likes to reuse the bile. But if you have lost your the final part of your small intestines here, now this bile ends up in your colon, where it works as a laxative, so it causes diarrhea. So we found in our standard care that if patients with neuroendocrine tumors come to the clinic and we find that they have diarrhea, 9 out of 10 of them will have at least an element of bile acid malabsorption, and this is something that's often missed. I saw a patient a few weeks ago who's been seeing a provider outside of our institution. He's had diarrhea for years, and no one has ever thought about the bile acid diarrhea being the cause of his diarrhea. And it often coexists with other causes of diarrhea. So very, very underdiagnosed. And it's kind of tricky to diagnose. We have a blood test called 7-ACE4 that may work, but sometimes you just treat it. We use drugs that were used in the past to treat high cholesterol, drugs like cholestyramine, cholestyramine, and so on. They're really safe drugs and can really be life-changing in terms of controlling the diarrhea. The pancreatic exocrine insufficiency is essentially the pancreas getting a little lazy from the somatostatin analog therapy. So the pancreas has a few jobs, including producing digestive enzymes to help you digest your food. It should produce insulin. But if you give these drugs, the somatostatin analogs, so octreotide, lanreotide, then the pancreas slows down and it doesn't produce as much of the digestive enzymes as it should. Same thing if you remove a big chunk of the pancreas. Now you have less pancreas, so it can't keep up with its day job in producing the enzymes. And you can have a condition called steatorrhea, which is not digesting the the food properly, and that causes diarrhea on its own. This is the diarrhea we treat with medications like Creon, over-the-counter digestive enzymes, and that can be super effective. Unfortunately, there is not a good test for this, so it's something that you sort of have to ask and probe. And if the diarrhea is like oily, stools are light in color, float in the water, sorry for being so graphic, that could be the pancreatic exocrine insufficiency, and that could call for a very different approach than some of the other diarrheas. So we won't talk much about the carcinoid syndrome diarrhea because that will be dealt with by others, but just a few of the risks specific to certain types of surgery. So if you have pancreatic surgery, we mentioned the diabetes and the digestive problems. If you have stomach or duodenal surgery, that's the top part of your small intestines, you can have deficiencies in B12 and copper and some other iron and some other vitamins, and also just altered digestion. So sometimes even to the point it's really uncomfortable to eat. And small bowel surgery, we talked about that. If you remove a lot of small bowel, you can have diarrhea just because you have insufficient small bowel left. And you can get B12 deficiency, which can happen over many, many years. Even 4 or 5 years after surgery, you can start having B12 deficiency. And then lung surgery obviously can cause symptoms like shortness of breath. So the diabetes, as I said, common after pancreatic surgery and with somatostatin analog therapy. The risk of getting diabetes on somatostatin analog therapy has been estimated to be up to 1 in every 12 patients. That's not trivial. Well, a lot of people will get diabetes as they get older, and the injections can actually speed that up. So now you're getting the diabetes quicker than you otherwise would have. Same thing with the everolimus or the Afinitor that can cause diabetes, especially if you give it with a somatostatin analog. So on the topic of diabetes, I just wanted to briefly mention the GLP-1 drugs. A lot of people are on these drugs now for diabetes, for weight management, and they are really, really effective. And as obesity is a leading cause of cancer, if we treat the overweight and obesity with these drugs, we're probably going to decrease the risk of new cancers. And then someone who's expected to live for a decade or 2 or 3 even after neuroendocrine therapy, that's important too to prevent other cancers. There are some concerns that these drugs may accelerate growth of certain neuroendocrines, especially pancreatic, but it's not been proven yet. But it's still a concern. So I tell my patients, if you really need to be on these drugs, you can, but use the lowest possible dose and just follow carefully with scans. And so we don't know yet. Maybe we'll learn in a few years that these drugs are perfectly safe. Maybe we'll learn in a few years that these drugs have some undesirable side effects on speeding up the cancer growth. But so far in humans, we haven't really seen any evidence of that. So I'm hoping this will turn out to be nothing, and these drugs will be found out to be safe. So moving on to just a few of the specific drugs that we use, and one class of drugs is this class called multi-kinase inhibitors. So this would be like cabozantinib and sunitinib, effective drugs for neuroendocrine, but can have some side effects: skin rash, that's hands on your feet, high blood pressure, sometimes diarrhea, tiredness, a decreased appetite, elevation of your liver numbers, can even drop your blood counts and cause intestinal bleeding, and then some other side effects such as hair color changes and the voice changes, hoarseness. I had one person who enjoyed singing in a choir, and he can no longer do that because of the hoarseness. Everolimus or Afinitor is also an effective drug for patients with neuroendocrine tumors and has its own side effects, most commonly elevation of the blood sugar and triglycerides. Often causes mouth sores, which we can deal with by dropping the dose and sometimes giving a steroid mouthwash called dexamethasone. A very worrisome but thankfully rare complication would be inflammation of the lungs called pneumonitis. It's like bad pneumonia with cough and shortness of breath. And that all of that typically goes away after you stop the drug. And you can even sometimes start it again, and then you don't have those side effects, especially if you start at a lower dose. As for the chemotherapy, so we use chemotherapy in neuroendocrine tumors, especially patients with pancreatic and lung neuroendocrine tumors. And the most commonly used treatment is Cape-Tem, or capecitabine and temozolomide. Thankfully, that has a very favorable long-term side effect profile for most patients. But there's a tiny, tiny little percentage of patients who get or are unable to eliminate the drug from the system, and they can get pretty ill if they've side effects. We have a test for that called DPYD that should be done before you start this treatment. Other chemotherapies, including the oxaliplatin that some patients may be familiar with, can cause neuropathy, and sometimes it can be irreversible. It just doesn't get better. So you have to be really, really careful with that. And then there are some thoughts that chemotherapy combined with PRRT can cause leukemia. So that leads us to talk about the PRRT, or peptide receptor radionuclide therapy, something like Lutathera, lutetium dotatate, and now possibly the alpha particle treatments. Incredibly valuable tools, very effective, can shrink tumors, can control symptoms really well, generally well tolerated, can drop your blood counts, cause nausea, sometimes some tiredness and loss and some hair loss. But a tiny minority, maybe 2 to 3%, will have a life-threatening complication called treatment-related myeloid neoplasia, or TMN. So TMN is really two separate problems, something called myelodysplastic syndrome, which is like a pre-leukemia, and then acute leukemia. So these are the two problems we worry the most about. And this is a complication that has a very poor prognosis, unfortunately, and is very, very hard to treat. And the risk may possibly be increased with prior chemotherapy, or chemotherapy given at the same time or later. In the US, we almost never give chemotherapy with PRRT. So hopefully we can reduce that risk. And we don't have a good way to predict who is at risk. If we had a good test, we could, but we don't. So just to summarize this and hopefully bring it all home now, is that the outcomes of patients with neuroendocrine tumors, even with advanced neuroendocrine tumors, are getting better. So patients are living longer and they have more chance of developing long-term side effects. And we have to be really, really vigilant, asking about that and trying to prevent that. And if it happens, properly diagnose it and treat it. We have to pay great attention to even the low-grade or mild side effects, as they build up over time and can affect quality of life. So we should be really honest about the benefits of the treatment and the risk of side effects, even because there are some treatments that are not super effective but can have a lot of side effects. And then we should never make decisions unless we have sort of carefully balanced the efficacy and the short and long-term side effects. And it's very important for you, the patients, to report these side effects to us. It's like with pain. If you don't tell me you are in pain, I won't know that you're in pain unless it's like really severe. Same with diarrhea, with neuropathy. You just have to speak up and let us know about your side effects. So that is it for me. Thank you very much for the opportunity to speak.
Incorporating patient voices in everything we do at NetRF is very important to us. In today's program, we highlight thrivership in 3 videos featuring people who share their experience with neuroendocrine cancer and what they have learned along the way. First, hear more about how education has helped them make informed decisions, advocate for themselves, and navigate life with greater confidence. And we know that health is the physical plus the emotional. It really is an acknowledgement of the strategies, the tips that someone can employ to really live their best life. And it is important to really consider the other aspects of someone's life, because they're not defined by their cancer. It's something that they have and that they manage with their care team and to the best of their ability. But they also have the opportunity to live a full and rewarding life.
We have many, many metrics that matter to us because we, the oncologists and the scientists, because we can measure them. But my favorite quote about this came from one of my mentors, and he told me, Mark, not everything that can be measured matters, and not everything that matters can be measured.
I am not dying of cancer. I'm living with cancer. I have so much joy in my life, and it's up to me to plan that joy and to accept that joy from other people. It's about living your best life now, because, and everybody should do this, but when you are all of a sudden diagnosed with a terminal illness, I think it's different that you start prioritizing joy.
I'm Jamie Metzel. I'm a technology and healthcare futurist and the author of 7 books. But when my dad had his diagnosis for stage 4 metastatic neuroendocrine cancer, I only had one identity, and that was a loving son. And I wanted to be as supportive of my father as I possibly could be. And part of that meant just being there emotionally. And as part of that process, I knew I needed to get smart as quickly as possible. And so I started scouring the world for the resources that I needed. And that's when I came across the NetRF and the NetWise podcast. And I'm an ultramarathon runner. And so in my long runs, I basically listened to all of the podcasts, and I really learned a lot. And that played an important role in informing many of the decisions that we made that ultimately, I think, bought us some additional time that we used very wisely, not thinking about medicine or healthcare, but thinking about family and relationships.
I'm a survivor. I'm not gonna give up. Yes. Yes. That's pretty much sums it up. That's what it is to me. I'm a survivor. This is a statement I always make. And I tell it to people. I said, we may have cancer, but cancer doesn't have us. It's just something that you have. But that has nothing to do with you and who you actually are. There's things out there that can be done that, we don't even know about. If we do not actually research, we do not inquire. I always like to make this statement too. Closed mouths do not get fed. If we keep our mouths closed, we're never going to get to be where we need to be and what we need if we don't talk about it. Because I didn't tell everyone when I first was diagnosed. I did not. However, I had to learn that I had to go back to my own philosophy. Closed mouths do not get fed. If I don't talk about it, how can I engage? How can I tell someone else what they need to do if I'm not following my own advice?
You would never really suspect a 23-year-old to have stage 4 neuroendocrine tumors. I've cried a lot. I've cried, I've grieved a lot, but I've also laughed, smiled, it's the whole broad spectrum of emotions. So it's okay to be sad. It's okay to feel lonely. You're a human being, you have cancer. Being an advocate for yourself. It's so easy to, go on Google, and even when you go on Google now, you're not really looking at the results. The first thing is an AI summarized, finding of or an answer of like whatever you're searching. And you can sort of fall into a rabbit hole and immediately trust that. I just think that, like me personally, I really wanted to know sort of the availability of treatments out there for me, as well as, I guess, the future and ever evolving landscape of like net therapy. And that's how I found NetRF, actually, because, I've done a lot of digging, believe me. NetRF has a lot of digestible and easy to understand information. And I love the monthly updates, as well as yearly with, that big one with all these sort of promising and upcoming treatment and therapy. That's stuff that I really like to look into. And for those newly diagnosed, there's hope. The landscape of NETs is evolving rapidly. A lot of the systemic and novel treatments weren't even available a few years ago. And so there's a lot of good progress there. So stay hopeful, try to keep your head up. I'm trying to keep my head up. I guess shout out to like all the people again on my journey. My oncologist, Dr. Pamela Coons, my surgeon, Dr. John Koonsman, who did a great job last week, and all of my friends and family, and my coworkers. I love you all and thank you all so much. I don't think they'll ever see this, or maybe, but yeah, I just want to let you guys know I can't be where I am today without you all.
Sequencing discussions can be a focus of a tumor board where experts from different specialties discuss cases. Let's listen as Dr. Koitkin moderates Inside a Tumor Board, How Doctors Make Treatment Decisions.
Welcome everyone to our Neuroendocrine Tumor Research Foundation Tumor Board. Today we will present one case. We are very excited that you're here, and we have an awesome panel of physicians for you here today. I'm going to start with the introduction. I'm Xavier Koitkin. I'm a surgeon who specializes in neuroendocrine tumor, and I'm from the University of Chicago. And I will pass it down to Thor.
Yeah, I'm Thor Anderson. I'm a medical oncologist and professor of oncology at Mayo Clinic in Rochester, Minnesota, and I specialize in taking care of patients with neuroendocrine tumors.
Hello, everybody. I'm Anju Han. I'm a medical oncologist. I specialize in management of neuroendocrine cancers, and I practice at UCSF, California.
Hi, everyone. My name is Andy Liao. I'm a medical oncologist from the University of Chicago, and I specialize in neuroendocrine tumors as well.
Hi, I'm Kim Perez. I'm a medical oncologist, specialized in neuroendocrine and cancer genetics at Dana-Farber Cancer Institute in Boston.
Hey everyone, I'm Uday Grewal. I am a medical oncologist at the Winship Cancer Institute of Emory University in Atlanta, Georgia, and I specialize in GI malignancies and neuroendocrine cancers.
Again, thanks all for being here today. We really appreciate you taking the time. I will present to you one case today that I'm sure you've seen many times in your clinic, but I think it is nevertheless an interesting case. All right. So our case today is a 58-year-old male that presented in November of 2016 with flushing, diarrhea, and cramping. And purposely this time around, I added some dates so that we can see sort of the longitudinal evolution over time of this particular case and this particular patient. An outside hospital CT showed some liver lesions, and a liver biopsy was performed at that time, which showed a well-differentiated neuroendocrine tumor, grade 1, low Ki67, less than 3%, and obviously, because of the liver lesion, it was considered stage 4 disease. His urinary 5-HIAA was 9, so that's double normal, and his chromogranin A was over 1,300. Here is a dotatate PET CT that was performed at the outside hospital, and the quality is not the best, but it is an old one from 2016. And you can see some liver lesions here, as well as some, maybe a primary tumor or maybe some peritoneal deposits there. The question is to Kim, let's start with you. When you see a patient like this that presents in your practice, what would you think is perhaps needed, and what would you talk to them about, and what is your first step in treating these patients?
So a lot of things come to mind. So I think the first and foremost is just the symptoms that the patient's experiencing. And with the information that's been collected already, is the fact that the patient's having the flushing, the diarrhea, and cramping is going to direct what my recommendations for first treatment will involve. And so what has been described suggests what has traditionally been called carcinoid syndrome. And so kind of independent of the distribution of disease that we're seeing on imaging, now that we have a liver biopsy that confirms the histologic diagnosis and we have an elevated 5-HIAA and confirmed with the nuclear medicine imaging that there's somatostatin receptor uptake, starting a somatostatin analog to help with symptoms, and then counsel a patient that kind of getting the two for the price of one. So hopefully symptoms will improve, but also a therapeutic modality that will help control disease burden.
Thank you very much. That's exactly what was done. So at the outside hospital, they started this patient on long-acting octreotide. He did experience some improvement in his flushing and diarrhea. He did, however, still have some persistent occasional cramping. So at that point, which was October 2017, so that's almost a year later, he was referred to us. And Aman, is there something else that you can think of, perhaps that this patient would need? So the cramping is sort of still an issue, but the symptoms overall are pretty well controlled. Are you happy with this, or are you going to investigate more things, or perhaps refer him somewhere else?
Yes. So the cool thing about neuroendocrine oncology is there's always multiple right things to do, and keeps us, on our toes. One thing I'd like to make sure we keep an eye on the cardiac functions. We know that patients with elevated serotonin and carcinoid syndrome are at risk for carcinoid heart disease. So making sure that patient is getting annual echocardiogram, and if there are any concerns there, having cardiology involved. So I gather between 2016 and 2017, patients is hopefully radiographically stable, clinically improved. However, in carcinoid syndrome, there's always a value in reducing serotonin levels by debulking. And we can debulk the tumor either through liver-directed therapy. I see nice juicy lesions that can be targeted, or surgical debulking. Had this patient been non-functional, I think we probably not touched the patient. But in this particular scenario, there is concern of primary being there, which may obstruct down the road. On top of that, there are easy to treat liver lesions, which, if targeted appropriately, can reduce the load of serotonin, helping with the syndrome control as well. So I think if patient is fit, this would be a good time to approach debulking strategies with the patient.
Okay, so music to my ears. He did undergo a TTE, actually even a TEE, because the TTE wasn't that straightforward in terms of a good window. And he was found to have a mildly dilated tricuspid annulus, which is essentially what holds the valve in place, with very mild reflux. His serotonin, which you mentioned, was remeasured. It was 1200 at the time. And cardiology has seen the patient and did not at the time recommend any cardiac intervention. There were some blood pressure issues that they wanted to manage, obviously, but they felt that his cardiac function was good, and there was nothing else to do. Now, you mentioned surgical debulking, you mentioned bland embolization. Andy, is there anything else you could think of in terms of early therapy? We don't think the patient is progressing right now, but is there anything else? What are the options that we talk to patients about in this scenario?
Yeah, so if their disease is radiographically stable, but they still have persistent symptoms, like they're still having a lot of diarrhea, sometimes we talk to them about, short-acting octreotide rescue shots or telotrestat, which is Zermello, to better control the carcinoid symptoms.
Perfect. So we talked about bland embors, Zermello, which you just mentioned, short-acting octreotide. Thor, what about PRT in this scenario? We hear talking a lot about lately using PRT earlier. Is this a patient where you would use PRT early?
So for this patient, I wouldn't. So that study is currently ongoing, looking at upfront PRT compared to a somatostatin analog. So we don't have the results yet, so I wouldn't do that. I would rather just focus on managing the symptoms. And a couple of points I'd like to make here is, number one, I think sort of subtle obstructive symptoms in patients with small bowel NETs are very underreported and underrecognized. So, I would have a low threshold for removing the primary tumor if those crampy abdominal pains continue. The other thing I'd like to say, and I know that you've heard me say this multiple times before, is that the other complications of therapy, both bile acid diarrhea and diarrhea from pancreatic and exocrine insufficiency from essentially the pancreas not producing enough enzymes to digest the food that you eat, can also contribute to the diarrhea. So not all diarrhea in patients with neuron tumors is Kertman syndrome. Just want to put that out there.
Exactly. That's a great point to make. Uday, do you have anything else to add there from a GI perspective? What about colonoscopy, anything like that?
Yeah, I wouldn't go for a colonoscopy here. We know most commonly, I don't know if the PET scan clearly pointed towards the primary, but most likely this is going to be an ileal primary, and colonoscopies and other endoscopic interventions really don't help us identify. Could argue CT enterography can sometimes be helpful, but I think the best identification of the primary is done in the hands of the surgeon in the OR. I agree with Thor that a lot of these symptoms with the primary can be so subtle. That's why there's a lot of like controversy around like prophylactically removing the primary in patients with subtle symptoms or no symptoms. But I would definitely consider that, although in this case, there's the added risk of concomitant carcinoid heart disease. So if cardiac function is optimized, that's something that could be considered. But in patients with low-grade metastatic small bowel neuroendocrine tumors, where there's carcinoid syndrome, especially where there's also comorbid carcinoid heart disease, I find liver embolization to be an excellent modality that really does a great job in reducing the serotonin circulatory load, and at least makes me feel better that the carcinoid heart disease would not get any worse, and also remarkably helps with the carcinoid syndrome symptoms if they're not adequately controlled with somatostatin analogs or maximal dosage of somatostatin analogs. So that's something I would consider. There's a nice liver lesion that could be easily targeted, at least based on the PET scan.
Very nicely said. In this case, I targeted the liver lesions. We brought the patient to the operating room for all the different reasons that you all mentioned, right? Lowering the serotonin level, potentially preventing a blockage. You all mentioned all of these reasons. Of course, keeping in mind that, with a cardiac function, it was good in him. We weren't really worried about his cardiac function, but absolutely, before we take anybody to the operating room, we have to make sure, they get an echo and they get cleared by cardiology. So we did an extensive debulking. We did find some peritoneal deposits. So this patient had peritoneal disease. It was relatively limited and it was mostly down in the pelvis. So my approach surgically is that I will take everything out that I can in the pelvis, but I won't go too deep into trying to, take smaller deposits out that perhaps are laying on the rectum or so, because I don't want to risk a rectal injury. And in my experience, these deposits rarely cause any issues long term. So got a limited pelvic peritonectomy. Like you said, Uday, he had a small bowel neuroendocrine tumor. The mesenteric mass was resected and the liver was debulked. So his pre-op serotonin level was 1200. His post-op serotonin level normalized as we expect, which is good long term. We all agree. And this is a post-operative CT. Now, this is November 2017 at the University of Chicago. We generally don't resume patients on long-acting octreotide in this situation unless they have persistent symptoms, especially if we are happy with how the MRI looks. But about 2.5 years later, recurrent surveillance, everything looked okay until 3 months before. He noticed some return of symptoms, in particular flushing. His serotonin level now slowly creeped up and was above 600 at the time. And we obtained a dotatate PET CT that, as you can see, looks a lot better than the one before. However, obviously, as expected, there still is a small amount of residual disease left behind. Now, at this point, what would we do? So, again, I know I'm not showing you 3 years worth of scans here, but essentially you got to trust me on the point that the MRIs look pretty stable. The PET scan looked relatively stable, but we're in a situation where patients has a recurrence of symptoms. The most recent PET scan didn't show any clear progression. However, the serotonin level is creeping up. Number one, do we see this? Is this common that there's no obvious radiographic evidence of progression, but the symptoms return? And number two, what will we do in those situations?
So the number one question was, do we see this?
Yes.
Yes, I would say definitely. And I think what is important in these situations is our first inclination as medical oncologists is to restage with imaging and get a sense of what the disease burden is. And it is not uncommon for us to see a very unremarkable scan. What drives the next step is what symptoms are returning. And let's say it's just gastrointestinal symptoms alone. You have the serotonin level here, maybe it wasn't, which is significantly higher. You can start somatostatin analog therapy with the assumption that if there is disease, even if occult disease, it can still be the source of the serotonin excess that's causing the symptoms, but also recognizing that the patient has had surgical resection of their bowel, that you want to consider other etiologies for the diarrhea if that happens to be the symptom that they are describing or endorsing.
Absolutely. That's a great point, right? Listen to the patient and make the difference between the symptoms.
So with regards to the treatment, the DOTA-TATE PET scan is actually very reassuring in terms of it's a very low volume disease. Although patient does have some visible disease and has symptoms, the burden of disease is so minimal, we don't want to pull the trigger on big guns yet. Restarting SSA would be a very low-hanging fruit, which will solve two problems. One, carcinoid syndrome. Second, it's a bona fide anti-tumor effect, right? So it'll stabilize the disease and it's relatively well tolerated. So in NETs patients, maintaining quality of life is really, really important. So I would advocate for starting SSA and then understanding the tempo of disease, how patient does on that.
Perfect. So this is exactly what we did. So right now we're 3 years later. Again, I put the time frame on because it's important, I think, for our patients to see how drawn out we can go here and how we always say it's a marathon, it's not a sprint, right? We want to use the right therapies at the right time, and sometimes we just don't do much. So in this case, he was restarted on long-acting octreotide. And 3 years later, lo and behold, again, his symptoms returned. Again, his serotonin's creeping up again. And there's some mild progression on PET, right? So this now looks like a little bit different than last time, right? We could all argue it's still pretty low disease burden overall. Thor, what are you thinking?
Yeah, so here, the first thing that always comes through or goes through my mind is there still a reason to do some regional therapy like embolization or ablation where we can knock out the culprit lesions that produce the serotonin and cause the symptom? And then keep going with the somatin analog. So I know this is not well studied, but in practice it actually works. And so I would take this particular case to tumor board that would discuss this with interventional radiology, with surgery, and sort of look at all of those options. And if they say, nah, there is really not much that we can do in terms of putting needles and burning these lesions, then I would really start taking up PRRT, because PRRT not only controls tumor growth, but also very effectively controls symptoms. So that's what I would consider.
Perfect. Andy, are there any things in particular when you look at a PET scan that would sort of make you lean more towards liver-directed therapy versus PRT?
Yeah, so I want to see where the distribution of the disease is and where the changes are. So if the tumors are mainly in the liver or the tumors that are growing, so the changes are mainly in the liver and the rest of the disease is stable, then perhaps that would sway me towards more liver-directed therapies. But if the tumor is widely distributed, so in the liver, but also outside the liver in the peritoneal cavity, then sway me to do something more systemic like PRT.
Perfect. And in this case, to all of your points, which are very good and very well taken, we thought that the progression was more systemic. There wasn't really a very dominant lesion that we thought would be worth targeting. So we did go to PRT. Now, he received PRT in July 2023. That's where he started cycle number 1. And he had some improvement in his symptoms, which is great. His serotonin did drop after cycle number 2, which is also great. But then something happened that sort of was a little bit unusual, at least I would consider this unusual, is that he experienced progression of liver disease on the MRI in May 2024. So this was barely a few months after he has received PRT, at which time we decided to do blend embolization. But if we take a step back, so basically we changed the sequence, right? We went to PRT and then blend embo versus blend embo and then PRT. But how often do we see patients with a small bowel well-differentiated neuroendocrine tumor that has progression so quickly after PRT? And is this something that worries you?
I think we see it. I don't know if I would say I'm necessarily worried when the burden of disease is so limited. I think we're still very much learning about the right patients for PRRT. And so I wouldn't say that because of a case like this that I'm less inclined to give a patient with small bowel neuroendocrine with a Ki-67 less than 3%, PRRT, because I think that there's a trend that we're going to see that supports this. I think it's like any other systemic therapy. There's just some patients who respond in there, and there's some that don't. And we saw that in the published trials and all the prospective trials. It wasn't a home run, but when it did work, it worked very effectively.
Just a quick comment. I agree with Kim. Usually net PRRT works really well, especially in the low grade, like, this is a typical grade 1 net. But to answer your question, I think maybe 2 in 10 patients don't respond or have primary PRRT refractory disease. Usually those patients are higher grade 2 and maybe even grade 3 well differentiated nets. So this is a very unusual, and it's difficult to predict, and we don't really have good validated biomarkers to unfortunately predict. Now, in theory, very small volume disease may be best suited for alpha PRRT, but again, that's all experimental and these are trial questions, right? And we only have beta agent available in the US. But in theory, if we had both the options available, maybe alpha would have been a better suited agent in this situation.
I do want to point out that when we see progression in these cases, either there are more number of lesions or there are existing lesions that are growing bigger in size. So I find it very challenging in my own practice comparing apples to oranges. I try to sway away from getting repeat PET scans for surveillance imaging or response assessment unless there's like a decision that I need to make for PRRT or otherwise, or there's heavy osseous metastatic disease. So I repeat PET scans more often. But I like to go for anatomical imaging. So there's some consistent imaging to compare between, especially when we see more number of lesions. There might be some smaller lesions that are not captured on a PET scan, but if you do a nice CT scan with an arterial contrast, or you do a nice MRI liver with an EOVIS compared to the more conventionally used GATOVIS, you might see more liver lesions. So that might not, if the progression was more number of liver lesions, there might be a case where you're just seeing them more in the current PET scan, but they've been sort of lingering around and it's not really as clear cut of a progression as it may appear when you compare a PET scan to an MRI. The other thing I want to say, if there's a progression in terms of like existing lesions growing bigger after PRRT, I mean, it's a poorly defined phenomenon, but there's certainly that real phenomenon of pseudoprogression with radiogenic edema, something to be mindful of.
I think all very good points. And to your points, MRI with EOVIS is what we usually use for regular follow-up, and then we'll do a PET scan every once in a while. I know Thor at Mayo, they use PET MRI, at least in certain situations. But for time's sake, let's move on here. After the bland embolization, patient sort of had disease stabilization on the MRI a month after that, but then about 5 months later, had another PET scan, and this is what the PET scan looks like. Andy, does that worry you?
It seems like a pretty significant progression compared to how the disease has been doing since 2016. And so that will make me worry that something has changed, and I would consider doing a biopsy.
Okay, so this is exactly what we did. So we did a liver biopsy. It was a well-differentiated net, grade 2 at this time. CAT-C7 was 9.3%. We also do DNA analysis of the tumor called OncoPlus at the University of Chicago, but there were no pathogenetic findings and really nothing significant in terms of additional variant of unknown significance. But Thor, can you talk to us briefly about the mutational tumor burden, why that's important, and why the microsatellite stable report is also important for you in those particular cases?
Absolutely. So if you have a high tumor mutational burden or TMB, or if the tumor is what's called mismatch repair deficient or microsatellite unstable, then immunotherapy with drugs like pembrolizumab, nivolumab, durvalumab, those kinds of drugs might actually work really well. It's uncommon in small bowel nerve tumors, probably well under 5%. Honestly, I do not think I've seen many. And small bowel nerve tumors are very different from pancreatic nerve tumors. So the small bowel nerve tumors tend to have very few tumor mutations, while the pancreatic tumors are much more likely to have that. But we should always look, especially if you're dealing with someone who's been in prior therapy and treatment is no longer working. Getting a biopsy, getting genetic testing, I think is generally a very good idea.
Aman, what are the treatment options now? We have a patient that has received PRT, didn't respond well, right? Progressed pretty rapidly, had bland embo, kept progressing. Now we have a higher grade of disease, right? We don't have anything really significant on the DNA or OncoPlus analysis. So what's left on the table for this patient?
Well, we have quite a few options. By the books, everolimus would be an option. Cabozantinib could be another option potentially. What worries me is the pace of the disease. It's progressing within the months of PRRT. KIP-10 or chemotherapy may actually be another option. I usually use it more for pancreatic primary, and midgut primary usually are not that chemo sensitive. However, whenever you have a fast tempo disease, kind of like this, I may entertain a brief trial of CAPE-10, stabilize the cancer, and then pivot to other strategies later.
Andy?
Yeah, I completely agree. I think the pace of the disease is a little bit worrisome, while everolimus and cabozantinib could be considered as well. I think that I would be thinking about chemotherapy as well.
So that's what was done, but we started this patient on CAPE-10. I can tell you historically that he had disease stabilization for 6 months, and then he progressed again. So additional options as a last sort of case scenario, we talked about everolimus, cabozantinib. He's already had CAPE-10, IV chemotherapy. Is this a patient that would qualify for retreatment with PRT? That's my first question. And my second question is, if patients see this case like I presented it, is this something that should worry us as physician, or would you still think that PRT is a really good therapy and that we should continue using it?
Obviously, I agree it is concerning that there is a increase in rate of growth, or the kind of the character or phenotype of the disease is changing or evolving. I would only favor reconsidering PRT if it was part of a clinical trial and we were considering a different theranostic agent, like an alpha versus a beta emitter. Again, a little bit into the weeds, but I think that's important to note. I think what troubles a lot of patients who find themselves in this situation, even in this situation, we actually fortunately see a change in the Ki-67. So it kind of follows what we're seeing clinically, where we're not always fortunate to see a change in the Ki-67, yet we see this clinical change in the rate of growth, is that we just have to start thinking kind of outside of the box and not being so limited by what we had started with, and counseling patients in regards to there was going to be a point in time where the disease was just going to start to act more active, and we are yet to have biomarkers or tests to tell us when that's going to happen, and for what we traditionally think of as a very indolent disease. And I think the course of many years for this patient has proven to follow the textbook until the scan and then the short course of chemotherapy.
I'll punt it back for the last answer to Uday. Should patients be worried about PRT when we see cases like this? I mean, do we see this often, or is this something that's pretty rare?
Yeah, it's definitely not very common, but also not rare. I agree with Kim. I would not consider repeat PRRT in this setting. I have a metric in mind that I use when I'm deciding about repeat PRRT. We know from our own experience and also published experience from other centers that PFS with repeat PRRT is roughly half of PFS1 or PFS with initial PRRT. I like to see at least a year of PFS, so hoping for another 6 months with repeat PRRT. But alpha PRT really offers a ray of hope, especially in this setting. We know Action 1 completed accrual last year, and we should get results at some point in the future. I think that would be an excellent option to consider, especially for patients like this. And other than this, I mean, there are certain concerns about long-term safety and efficacy of both repeat PRT and alpha PRT when it's used as a salvage option. So I don't think we have reliable, robust prospective data in this setting. I just counsel patients that we don't really know what the long-term safety data is in this setting. But if they have preserved organ function, both hematologically and renal function, I offer it sparingly in the right clinical context.
Great. Any other burning comments?
I'd just like to mention one change that has recently happened. So the latest WHO classification for NETs is out. And it's largely all same, but the WHO has acknowledged this entity that we had been seeing lately in the last 4 or 5 years, this transformation and these indolent tumor becoming more aggressive, especially after PRRT or various lines of treatment. As our patients live longer, we are seeing, and so they call it G3 NET with neck morphology or NEC arising from NET. So sort of they have not firmly labeled it, but they have acknowledged that this can happen, to your point. Fortunately, this is still rare, But whenever this happens and the disease biology changes, I think rebiopsying and checking for TP53 or RB1 loss and some of these biomarkers, very crucial, presence of necrosis if it wasn't there, that kind of tells us, okay, there's clearly change in the biology and we might have to pivot to IV chemotherapy.
Okay, thank you very much. Thanks all for being here today. I hope you enjoyed the case, and I'll give it over to you.
Our next speaker is Dr. Aman Chauhan. He is an associate professor of medicine at University of California at San Francisco. Dr. Chauhan's research and clinical work focus on neuroendocrine cancer, including faster growing and poorly differentiated disease. He'll cover treatments for faster growing neuroendocrine cancers, including neuroendocrine carcinoma and grade 3 tumors.
Hello, everyone. Greetings from California. My name is Aman Chauhan. I'm an associate professor of medicine and a neuroendocrine tumor specialist at UCSF. Today, we will be discussing management of high-grade or grade 3 neuroendocrine neoplasms. As you know, neuroendocrine cancer is not single disease. Based on the site of origin, these neuroendocrine cancer can stem from various organ systems. My talk is focused on high grade, so I would like to spend time on different flavors of high grade neuroendocrine cancers. While lung or small cell lung cancer is the commonest variety of high grade neuroendocrine cancer based on the prevalence and incidence, but these high grade neuroendocrine cancers do occur beyond lung, and we club them as extrapulmonary neuroendocrine carcinomas. And I've seen patients with breast cancer, genitourinary tract, high grade neuroendocrine cancer. Many can develop these high-grade neuroendocrine cancer from GI tract, from colon, pancreas. It's also not uncommon to see these high-grade patients from head and neck region, tonsils, larynx, etc. So the bottom line is these high-grade neuroendocrine cancers can originate from various organ systems. The presenting symptoms depends on the site of origin, mass effect from that tumor, pressing on to the nearby structures, or sometimes could be asymptomatic as well. Before we go further, let's take a deep dive into the different gradations of neuroendocrine cancers. Here in front of you, you've seen well-differentiated neuroendocrine tumor on one end of the spectrum and neuroendocrine carcinomas or poorly differentiated neuroendocrine cancer on the other end of spectrums. Based on the organ system, for example, in lung, these are often called typical carcinoid, atypical carcinoid, and poorly differentiated carcinomas like small cell and large cell neuroendocrine carcinomas. Outside lung, especially GI tract, we often call them NETs or NECs. And between NETs, there are further subdivisions, grade 1, 2, and 3, based on the Ki67 or mitotic index. For today's talk, I'm focusing more on high grades. By definition, high grade means grade 3. And as you can see in front of you, there are two forms of high grade. Either you can have well-differentiated high-grade neuroendocrine tumor or poorly differentiated high-grade neuroendocrine carcinoma. So with that understanding of the different forms based on the morphology and grade and different types of high-grade neuroendocrine cancer, let's first understand key management principles of high-grade neuroendocrine carcinomas. These are some of the guiding principles that I follow. The treatment that we use in our clinics for high-grade poorly differentiated neuroendocrine cancers actually stems from small cell lung cancer paradigms. For example, the standard of care for the frontline management for extensive or advanced disease is a chemo regimen called platinum doublet, cisplatin etoposide or carboplatin etoposide. And we have inherited this regimen from small cell lung cancer, and this has been in use since 1980s. However, 5-FU-based regimen can also be used, especially if a high-grade neuroendocrine carcinoma is of GI origin, colon or pancreas, and oftentimes we will also entertain FOLFOX, FOLFIRI, and even FOLFIRINOX in a very healthy patient. However, this being a rare cancer with very poor outcomes, clinical trial participation is highly encouraged. If we find a breakthrough, which I'm very hopeful we will in near future, this will come through not through standard treatments, but through clinical trial participation. Once patient progresses on the initial or frontline treatment with carboplatin etoposide or a platinum-based regimen, subsequent line of therapies often include alternating different chemo regimens, making sure that the mechanism of action is distinct. So if somebody's tried the platinum, maybe we can try topoisomerase or alkylator-based chemotherapy. So switching from carboetope to FOLFIRI or FOLFOX or trying CAPE-10. That's one of the strategies we use for standard of care. Ipilimumab and nivolumab, these are immune checkpoint inhibitors or immunotherapy drugs, is very commonly used for several cancer types. However, they don't work as well as we often see them working in lung cancer, kidney cancer, and several other cancer. However, in a small study called SWOG-DART 1609, this combination of ipilimumab and nivolumab was tested in high-grade neuroendocrine cancer with some activity. And based on those results, Ipi-Nivo is considered standard of care and is endorsed by NCCN guidelines, although it's a weak recommendations cut category 2B. So there are few patients who may respond to this immunotherapy combination. Beyond that, there are some targeted therapies that can be considered, and these are agnostic to any tumor type. So for example, if somebody has NTRK gene fusion or a BRAF V600E mutation, there are certain drugs that are already FDA approved regardless of the cancer type. Could be high-grade neuroendocrine cancer, could be breast cancer, could be colon cancer. So these are what we call cancer agnostic indications. And for that reason, we always encourage to check the tumor tissue for targetable mutation and their molecular profiling to look for these rare but important mutations. As I mentioned before, the key breakthrough will come through clinical trials. Our standard treatments are effective, but the response lasts for a very short period of time. And majority of patients, unfortunately, develops resistance to these chemotherapy drugs, and the patient has progression. So we are looking for novel targets, and the most promising of the lot right now is a target called DLL3. It is heavily expressed in all high-grade neuroendocrine carcinomas. Small cell lung cancer expressed in over 80% of the cases. But even outside lung, as you can see, majority of high-grade neuroendocrine cancer, regardless of their primary site of origin, they tend to express DLL3, making this as a very lucrative target for drug development. So what drugs are currently being developed for this target? The first drug, tarlatamab, which is a DLL3 T-cell engager, is already FDA approved for use in extensive stage small cell lung cancer based on a study called Delphi. The study showed almost 70 to 80% clinical benefit rate, close to 30 to 40% response rates, that means shrinkage capacity. So drug is very, very effective in second line onwards and is now being tested in various combinations with chemotherapy and immunotherapy for frontline in small cell lung cancer. But would this class of drug also work for high-grade neuroendocrine cancer outside lung? The early data from some of these studies looks very promising, and there is reason for optimism that these drugs will be active in high-grade neuroendocrine cancer, even outside lung. And the classes of these DLL3 targeting agents are not just one with just T-cell engager, but we are also seeing smart chemotherapies. These are called antibody drug conjugates, where a drug is designed to target the DLL3 positive tumor and the payload is a chemotherapy. Similarly, radioligand therapies, we all know about PRRT for well-differentiated, especially low-grade NETs. Similar concept is now being applied for high-grade neuroendocrine cancer. These radioligand therapies or targeted radiation-based treatments, they target DLL3 positive tumors, and they're linked to this radionuclide, which emits radiation and radiates the tumor. And most recently, even CAR T therapies, these are patients' own T cells or immune cells, which are extracted from their body, bioengineered to then latch onto the DLL3 positive tumor cell and kill them. Just last week at ASCO, a fantastic phase 1 study results were presented on small cell lung cancer patient. So there's a lot of drug development is happening in this space, which is targeting DLL3. The most promising study that is showing some efficacy signals in high-grade neuroendocrine cancer outside lung, especially GI origin, is coming from Darien 5 study, which is a phase 2 study Dr. Capdevila recently disclosed the results from this phase 2 international multi-center study. As you can see here, patients who got the DLL3 T cell engager called obrixtamig, drug very similar in concept to tarlatamab, they're showing some significant efficacy here, but especially if patients were high DLL3 expressors. So what we are learning in extrapulmonary or outside lung high-grade NEC patients, if you are DLL3 positive, especially more than 50%, these patients tend to have deep, durable responses. These are called swimmer's plot. The longer the line, the longer the patient stayed on treatment and did not progress. There is another study that I was part of called Darion 7 and recently presented data. So when you have an effective drug, in this case, obrixtamig, and showing some efficacy, the natural transition is to bring that drug up front in the frontline setting. So in this phase 1 study, we tested obrixtamig in combination with standard of care frontline chemotherapy. And what you see here is the waterfall plot. These lines that are hanging down that shows those patients had disease shrinkage. So fantastic results. Almost 75% patients showed shrinkage of the cancer to this frontline combination chemo and this novel immunotherapy called obrixtamig. There are some other classes of drugs that are also being investigated in high-grade neuroendocrine cancer. You may be aware a lot of patients gets chemoimmunotherapy per standard of care. However, that is standard of care for small cell lung cancer. It's often extrapolated to high-grade neuroendocrine cancer outside lung. But we truly don't know if the standard immunotherapy, Tecentriq, adds to the benefit or not. So this very important cooperative group study that is currently enrolling in the US at various sites is investigating chemo versus chemo plus immunotherapy. And this study would answer whether there is role of adding Tecentriq or immune checkpoint inhibitor in the frontline setting in high-grade neuroendocrine cancer. Last but not the least, we are also doing our own innovation. This is a study that I designed with help of Seneca Therapeutics, an oncolytic virus study, where we are injecting the oncolytic virus directly into the tumor and combining with standard of care ipilimumab, nivolumab, with an intention that this oncolytic virus would trigger the immune response and make these less immunogenic cancer into more immunogenic cancer. That means they will respond in a better way to immunotherapy or immune checkpoint inhibitor therapy. And this concept was based on the animal model, and the study is sort of halfway done. And very soon we are also planning to open at UCSF besides University of Miami. So that was a whirlwind tour of how do we treat high-grade neuroendocrine carcinomas, NECs, and a lot of excitement in DLL3 targeting space, especially with obrixtamig taking the lead when it comes to extrathoracic high-grade neuroendocrine carcinoma for drug development. Now, let's spend a little bit of time on how do we treat well-differentiated grade 3 NET. Remember when we started our talk, I showed you that there are two flavors of high grade 3 well-differentiated NET and grade 3 poorly differentiated NEC. So there are some subtle differences. First of all, grade 3 well-differentiated NET especially, there is no one-size-fits-all approach. You have to really individualize patients' management plan because by definition, a grade 3 well-differentiated NET means anybody who has well-differentiated morphology and has Ki67 more than 20%. So you can imagine that there are some patients with 22% Ki67 and some patients with Ki67 70%. We clearly cannot treat them both similarly. So we have to understand their Ki67. We have to understand their tumor growth rate and presenting symptoms. Some patients may present with very fast, rapidly growing tumor growth rate, and that is causing visceral crisis or symptoms from mass effect. So those patients need urgent treatment, fast acting treatments. We can shrink the disease. Also, very important aspect of well-differentiated NET is many of these patients will express somatostatin receptors like our low-grade NET patients. So it's important to do a DOTA-8 PET scan to understand their somatostatin receptor expression so we can also factor in role of PRRT for well-differentiated NET. This is in contrast to poorly differentiated NEC where very few of those have SSTR, so we don't even routinely check for somatostatin receptor in high-grade neuroendocrine carcinoma. So how do we treat well-differentiated NET? Well, just like other NET, the low-grade NET, the key pillars of treatment for well-different nets are SSA, somatostatin analog, targeted therapies like everolimus and cabozantinib, chemotherapies, and radionuclide therapies. But we are not talking any general NET. We are talking a subgroup of NET, well-defined NET, that is more aggressive or grade 3. There, the role of the treatments are the treatments which has the best evidence for grade 3 well-differentiated subset. In targeted therapy, cabozantinib, we have cabinet study. I'll come to that in a second. Chemotherapy is also commonly used, both KIP-10 as well as platinum-based chemotherapy based on the aggressiveness and Ki-67. And last but not least, lutetium-177 dotatate has a clear role in SSTR positive grade 3 NET in contrast to NEC. Okay, so let's talk a little bit about cabinet. Very important practice-changing study is a randomized clinical trial that studied both pancreatic and extrapancreatic NETs, included GI tract and thoracic NETs. Patients were randomized to cabozantinib, is a pill form of targeted tyrosine kinase inhibitor targeted therapy versus placebo, and progression-free survival was the key endpoint. But the reason why I'm flagging this study is they did include grade 3 NET patients. Very few prospective randomized studies had included grade 3 NET patients. So it's very, very important. And as you can see here, patients with grade 3 NET, the response rate was 25% as compared to 0% in placebo. So clearly, cabozantinib has activity in some well-differentiated NET patients and should be considered in well-differentiated grade 3 NET. So moving forward, I mentioned earlier that PRRT is also considered for well-differentiated grade 3 if patient has somatostatin receptors. How do we know? NETTER-2 study tested role of PRRT in grade 2, higher grade 2, that is Ki-67 more than 10%, and grade 3 well-differentiated NET, and randomized patient to lutetium-177 dotatate versus high-dose SSA. And what did we find? Before we go into the results, I want to highlight the fact that almost 1/3 of the patient belong to well-differentiated grade 3 NETs. As I previously mentioned, very, very few randomized phase 2 or phase 3 studies have included grade 3 NET patients. So this is very important data. And what did we find? It was a profoundly positive study. As you can see, the median PFS in patients who received lutetium-177 dotatate was 22.8 months as compared to 8.5 months in the control arm. This opens the door of using PRRT in high grade or grade 3, but well-differentiated SSTR positive patients. So this certainly can be considered one of the options. Last but not the least, I think we still need to develop more drugs when it comes to well-differentiated grade 3 NETs outside DLL3 targeting, which I think we need more data to see whether those class of drugs are also active in well-differentiated grade 3 NET space. We at UCSF are our own investigator-initiated study in this realm. Dr. Emily Bergsland is leading this study and adding lenvatinib, which is a TKI tyrosine kinase inhibitor, and combining it to immune checkpoint inhibitor Keytruda or pembrolizumab in this well-differentiated grade 3 NET cohort. So we need more studies in these areas, and hopefully we'll be making some breakthroughs in this rare but critical unmet need of the disease as well. With that, I would like to conclude my talk, and we will proceed with the discussion section. But I also want to highlight that this is a very quick, very high-level overview. One key take-home message here is there is no one-size-fits-all approach when it comes to high-grade neuroendocrine cancer patients. Please seek out a second opinion at high volume neuroendocrine cancer program so that we can help you and fine tune the treatment modality. And a lot of treatment does benefit from considering latest clinical trials currently enrolling for both well-differentiated grade 3 and poorly differentiated NEC patients. With that, thank you so much for this opportunity, NetRF.
Shared decision-making between doctors and patients can be especially important in neuroendocrine cancer. The path is not always clear, and there can be treatment options for patients to consider. New this year, we are going to get a rare look at real conversations between NET specialists and patients about treatment choices. In our next segment, Dr. Koikin talks with patient Lisa Williams. Together, they explore when is surgery an option.
Okay, welcome everyone. This is our NetRF video on treatment choices. As you know, this is new this year, and what we wanted to do with this particular session was to talk to one of our patients. In this case, it will be Lisa. Hi, Lisa. Thanks for being here today.
Welcome.
And I will ask her some questions about the surgery because we thought that it was particularly important to hear from a patient because they are ultimately the one that have to go through this, and having them talk about their experience is extremely valuable for us as clinicians, but also hopefully for you as patients in the future should you have surgery. So Lisa, first of all, like I said, thank you very much for being here today. We really appreciate you being willing to step forward and talk through your experience with surgery. I'll give a quick summary, Lisa, about your story, how you came to us, and then we'll talk about your experience with surgery. So you were diagnosed with a metastatic neuroendocrine tumor. You went to an outside emergency room with a bowel obstruction. Further scans showed that there were some lesions in your liver. Those were biopsied and showed metastatic neuroendocrine tumor. Then you were started on chemotherapy, which you did one cycle of, so roughly a month. But then in August, you still didn't feel well. Went back actually to the emergency room with an acute bowel blockage, at which time the surgeons brought you to the operating room. It wasn't me, it was done in an outside hospital. They resected a tumor that was in your distal small bowel, and they gave you a bag, or an ostomy as we call it. Then you had additional chemo throughout the fall, and that was hard on you. And especially in January, it sounds like, you had a lot of dehydration, nausea, nothing was like tasting or smelling good. So the chemo was definitely having a toll on you. And then you were also started on some nutrition through the vein. But then you came to see us, and this is where the question starts. So can you take us back, Lisa, to the first meeting with us, with Dr. Liao and myself? What did you think about the meeting? What did you understand at that point? And were you surprised by the recommendations we gave you?
When I first met with my oncologist last summer, she had told me that I was going to do 12 rounds of chemotherapy and then come to see you for surgery. So I wasn't necessarily surprised that I was going to get surgery on my liver, but I was definitely nervous going into the meeting. I didn't know if you would say I would be a good candidate or not, but I was definitely hopeful that you would say you could do it.
And how did you feel like we did in terms of trying to present the surgery to you? And why did you think that surgery was right for you?
Well, you talked about my lesions being well differentiated and that was a good thing. And you explained to me that biology was king. I remember you saying that a few times, and that we would do the lanreotide shots for a few months leading up to the surgery, just to see how my body responded. And if they didn't grow, then that would be a good thing, and that would make me a good candidate.
Exactly. I know that at the time with the ileostomy bag, if I remember well, but correct me if I'm wrong, it was still challenging for you, right, to manage that. And so were you excited to get rid of the ostomy bag? I'm assuming you were, but what was your thinking about that?
Yes, I was definitely ready to get rid of that. When I got in August, I didn't know how long I would have it necessarily. I was hoping maybe in January, by the time I was done with chemo, then I could get rid of that quickly. But then things changed when I wasn't doing well, being dehydrated and having to get the TPN and all that. That just delayed everything. So I was definitely looking forward to it, though. Yes.
And that was also one of the reasons, because like you said, biology is king, but in your case also, we wanted to make sure that, you're strong enough for surgery, right? So we wanted to give you a little bit more TPN, strengthen you, make sure your nutrition was good before we took you to the operating room, because obviously this is a big operation. Like I tell my patients, and you can certainly tell us more about this, but a big operation also means that it is challenging to go through this. And so we want to make sure our patients are as fit as possible. Did you feel like when surgery then finally happened in April, did you feel like you were prepared both mentally and physically, or how did you prepare yourself?
Yeah, I definitely felt so much better physically. It was definitely good for me to wait the 3 months to get that done. I feel like I tried to stay positive, and I just went into it with trusting you and your expertise, and that you would take care of it.
So nothing particular you did for preparation. You just had positive thoughts.
Yeah, well, we did. The logistics was the hardest part for us because we were coming from 3 hours away.
Yeah.
So that's the hardest part to figure out for us and my daughters and my husband. And we got an Airbnb within walking distance to the hospital, and that worked out really well for us.
So that's really important that you mentioned. We have patients like you sometimes that come from further away, and logistics is very important for preparation for surgery. Sometimes also because we give you averages, right, of time that you're going to stay in the hospital, but sometimes things can go longer, right? If you have a complication, you may stay in the hospital longer. Did you feel like your daughter and your husband managed it well? Did they stay in the Airbnb while you were in the hospital?
Yes, they did. And I was told 3 to 7 days. So that's a pretty big range. Then I ended up staying 10 pretty much. So yes, it was good to have a someplace close for them to be, to stay close. And they were there every day with me.
And how long did you stay in the area after
I
surgery?
ended up after going back, after I had a complication, and I went back after 6 days, and then I stayed another 4 days, got released on Saturday, and then we ended up leaving on Sunday. We kept extending our stay at the Airbnb as things went on.
Yeah. Okay. Well, thank God there was still availability and
Yes.
there was nobody else at point. So let's talk a little bit about the complication that you had, right? So as I'm sure you remember, I always tell my patients these are big surgeries and complications happen. But can you tell us a little bit about how you noticed the complication and whether coming back to the emergency room or to the hospital for you was a big bummer, or whether you were just like, okay, I know this is part of the treatment, I just got to get through this?
Yeah, well, I left on 6 days after surgery, as I said, and I was doing everything. I was eating, seemed okay that I left, and then but I still, once I got back to the Airbnb, I felt okay, but then about 4 hours later, I think, I felt like I was going to throw up, and I did. So I started throwing up, and then I ended up going to the ER. Yes, it was a bummer, but I feel like in the last year, I've had to learn to just roll with things, and that was what I had to do. So that's what I did. Yeah.
So you had a small partial blockage, right?
Right.
Was related to probably some of the scar tissue after surgery that happens sometimes. It's not common, but it does happen in some patients. We ended up not doing anything, right? Basically just watch you, keep you NPO, hydrate you, and then just wait until it passes, which it does in a majority of cases. And then you finally got on your way back. What was the first thought after this long journey that you had when you got home?
Well, it was Mother's Day, so it was a good present for me to come home on Mother's Day. I was just so happy to be home and starting, a new life in a way, after having the surgery and everything that you did with removing all the lesions. I know it's not over, but it's definitely a good start to not be on chemo and getting this done.
This is so great to hear that you actually got home on Mother's Day. I'm sure your daughter was very happy.
Yeah, they were both very happy, yes. And my husband, yeah.
So tell us a little bit about how you have done since surgery. Do you feel like you've really improved dramatically? Do you feel like you're a new person, or do you feel like, you're still struggling every once in a while and it's still hard? How do you feel?
No, I feel really good. I feel like myself again. I'm not having, I had a lot of pain last summer up until the surgery, and I feel stronger for sure. I'm able to exercise again. So I definitely feel like I've gotten a new start compared to where I was a year ago.
Yeah. And
Yeah.
this is sometimes what I tell our patients too, is that even in a recovery period, sometimes it takes time until you're sort of back to yourself, right? So
Yeah.
can you remember, I mean, now it's not that long ago, right? Surgery was in April, right? So do you feel, so we're at that sort of 3 months mark almost, and I tell most of my patients by 3 months, you should be sort of back to normal.
Yeah.
Do you feel like the first couple of weeks after you got home, you felt just more fatigued, more perhaps lack of energy, or you felt like, it came back pretty quickly?
No, it was definitely slow. Definitely slow. And with the big incision that I have, it hurt. It hurt. It felt, like stretched when I would walk. So I would just take short walks. Yeah, and I sat around a lot. I was tired. I had to take breaks, but just slowly got back to it.
And in terms of eating, was there anything that you felt like you just couldn't eat at the time after the surgery, or did you just slowly reintroduce all kinds of foods?
I was a little nervous when I started eating, just because I was afraid that something might be difficult, as far as the blockage goes or anything, but I can eat anything I want and I don't have any trouble. Yeah.
Great. And then are you on any treatments right now, Lisa? Are you getting the shots or we stopped everything?
No, I'm not getting anything. I'm just living my life.
That's beautiful. So this is one of the advantages sometimes with surgery, like patients in your case, where most of the disease is located in the belly. When we do surgery and we can remove a lot of it, we can actually get patients off the shots. And the exact goal is to do what you're just doing, going back to your life and doing all the things that you want to do and not having to worry about going to the doctor every month and getting a shot. So certainly one of the things. Now, as you know, Lisa, like you said yourself, it may not be fully over, right? We want to make sure we scan you regularly, usually about every 3 to 4 months the first year. How do you see the future for you? What are you hopeful about, and what do you think, things are going to look like over the next few years?
Well, they're definitely better than what I thought a year ago. That's for sure. The oncologist, she told us the statistics for me the first time we saw her, and it was very scary. But after talking to you about what you're doing with the research and everything and what you can do, I feel like I have a much better prognosis. Both my daughters are going to be doctors. One's going to be a vet, one's getting ready to go to med school. So I want to see that.
Yeah.
I want to graduate. So, and I feel like I'm going to do that now.
Yeah, I think you will too. So the last few minutes, if there is anything, Lisa, that looking back at all of this surgery experience and, the one complication that you had, but like you said, you powered through this, you kept positive. What would you give in terms of advice to someone who might be told that surgery is an option for them? Is there anything that you want to tell them?
I would definitely do it. Be flexible because things happen. You just have to go with it for sure. Stay close if you're from out of town, like we did.
Yeah.
But just be positive, and I think that's really important. I've learned that through all of this last year for sure.
This is fantastic. This is great advice. Well, Lisa, thank you so much for doing this today with us. I'm so glad you're doing well. This is the first year I said that we're doing a doctor-to-patient conversation. I have a feeling it's going to be highly successful, and you won't be the only patient we'll be talking to in the future. But this was really great to spend some time with you today. Thank you so much for all of us and for the physicians, for the patients, and for the providers. So thanks, and I will see you soon.
Thank you.
After your next scan.
Okay, thank you.
Now Dr. Liao returns, this time with patient Christine Meyer. They have an insightful discussion about PRRT and targeted therapy options.
Hi, everyone. My name is Andy Liao. I'm a medical oncologist from the University of Chicago. And today I have the great honor of interviewing one of my patients, Christine Meyer, who has been getting treatment with us since 2021. And so we are so grateful for her to share her story with us and walk us through her experience with PRT. So Christine, thank you so much for joining us. I think hearing your experience will be super helpful for other patients. Could you tell us a little bit about your treatment journey when you were diagnosed and what type of treatments you've been through so far?
Sure. So thanks for the opportunity to talk to other patients. I think it's really valuable to hear from a patient perspective. So I was diagnosed in the fall of 2020. My primary tumor was in the duodenum, and I had extensive liver tumors at the time. And my original oncologist said, well, we'll start you on these lanreotide injections. Surgery is not really an option for you. And these are slow growing tumors, and don't worry about it. And I wasn't satisfied with that answer. So I luckily live in an area where there are some great NET specialists, and sought out their opinions and started on a much more aggressive treatment. So I originally started the lanreotide injections, but also started on Cape-Tem, the oral chemotherapy. And I did that for about a year. And after several months on Cape-Tem, I was seeing some shrinkage in my tumors. And we made the decision to do a set of bland embolizations to further target the liver tumors. So I had those embolizations, which were very successful. And so after 2 years of having, I was on Cape-Tem part of that time and had the embolizations, I had enough reduction in the number of liver tumors that surgery became an option. So in 2022, I had surgery to remove the primary tumor and also to debulk my liver. So we couldn't get all of the tumors out of the liver, but it reduced them significantly. And after that, I was pretty stable for about 18 months, 2 years, with no real progression, and things looked really good. I was really happy with it, felt really good. But then we started to see kind of slow but steady kind of growth in the tumors, and went through another round of embolizations, and then towards the end of last year, started to see, again, some progression. Not like dramatic increases, but kind of slow, steady growth. So when I had scans, we thought, well, we probably need to think about what to do next. But at that time, I wasn't too concerned. I said, let's wait another 3 months, because I would like to put off doing things if I didn't have to do them. And in November, we saw the same, kind of growth again. So at that point, it was when we had to think about, well, what's going to be the next step?
Which would be PRRT.
Yeah. So we talked about several options, though, at that time. PRRT was kind of the primary one, but we did discuss perhaps going back onto the Cape-Tem, perhaps doing more embolizations. And both of those were options, but I was a little discouraged that the last set of embolizations hadn't really lasted, the effect hadn't lasted that long. So I was a little nervous about doing more Cape-Tem because I had been on it for quite a while before.
Yeah.
So, and I did think about like just not doing nothing. That was one of my questions, was what if we didn't do anything? And in the end, it seemed like PRRT was going to be the best option. And then thinking scheduling wise for me, to be honest, I still have 2 big vacations planned for the fall. So my thinking was, if we're going to do PRRT, let's do it now and get it over with. Because it is about a 6-month process.
Yeah, definitely plays into the consideration. So when you first heard about PRRT, how was it explained to you in simple terms?
The way I kind of understand and explain it to others is that you are infused with this radioactive substance that attaches to the receptors on the tumors. And then it delivers that radiation directly to the tumors. So it's very targeted to your particular tumors, and that like lessens the effect on the rest of your body. So I think one of the problems I have, and maybe this is a question for you, is explaining it to other people. I mean, the explanation is easy, but sometimes people say, oh, you're having radiation. And I said, well, it's not exactly the same as I think what people think of as radiation. So it'd be good to have like a good word for this. And I don't know if there is such a word that people would understand.
Yeah, it is a type of radiation, but it's different than radiation as people think of it, external beam radiation. So this is more like internal radiation, and is targeted to a specific marker that your tumors have. And treatment that like this are coming for other cancers as well. It's approved for prostate cancer, and it's in clinical trials for other cancers. So this is definitely coming. So it will become more familiar with people as it becomes more widespread, and then hopefully, when patients hear your story or other patients who've been on it, they get educated as well. You kind of touched about this earlier. What made you feel like this is the right next step for you as opposed to some of the other treatments?
I had been through several other treatments, surgery and Cape Tem and embolizations, and I'm still on the lanreotide. I've heard several, doctors talk about there being, several tools in the toolbox, and it just seemed like this was the next one to use, and the timing seemed right. I think in our discussion, there was some thought that PRT might be a little more effective while the tumors are a little smaller, so that timing-wise, I think that seemed between it being the next thing to do, the size of my tumors, the growth rate. After thinking about all the options, it seemed to be the best one.
Yeah, I think it was a great choice. And so, walk us through your experience with the actual treatment. What is it like day to day and visit to visit?
So I think the biggest thing I would say is it's a long day. So you're there about 7 or 8 hours. So other hospitals might be a little bit different, but I meet with the nurse first, and then you have to get 2 IVs started. And unfortunately, I have kind of small veins, so that can sometimes take a little bit of time to get that started. Once the treatment itself is pretty straightforward, you basically are sitting in a hospital bed for the rest of the day. So you'd think, well, why can this be so tiring? But I think mentally it's kind of exhausting.
Yeah.
You are hooked up to an IV all the time, so you are free to get up and move around. At our hospital, you stay in your street clothes, so wearing comfortable clothes is a good thing. You're going to the bathroom a lot, so wearing clothes that are easy to get to the bathroom is a good idea. It's just, it brings something to do. You are kind of limited because you have an IV, at least in one arm, the whole time. I go by myself. I think if you have somebody come with you, they have to leave once you get the radiation. So there's not really anybody there to keep you company. So you have to kind of occupy yourself. Something to read. I think there's a TV in the room. Bringing some snacks and things is good. They encourage you to drink a lot, which is good. So I liked having my own water bottle that I'm comfortable drinking out of. But it's just a long day. You're just there a long time, and
definitely.
it just kind of wears you out. Not so much because it's physically painful or demanding. It's just a long time.
Yeah, being in a room for 8 hours.
Exactly.
Yeah.
And you are kind of
And
limited what you can
yeah,
do.
yeah. What are the treatment side effects like, and how did you manage them?
So I've been, I think, pretty fortunate. I haven't had any really serious side effects. They give you anti-nausea medication at the time, and I haven't had any nausea afterwards. The nurses did say that medication lasts for like 48 hours. So that worked for me. I think my biggest side effects were I was tired, not like super fatigued, but just a little more tired. And, I would take a nap. I think with each treatment, that fatigue has maybe increased a little bit. So I've had 3 treatments so far. And after the third, I think it took me a little bit longer to kind of bounce back. The other kind of things I've noticed is my sense of taste changed a little bit for a few days. I did have some thinning of my hair. That happens about maybe 3 weeks later or so. And for me, it wasn't dramatic, but you did notice it. And I think those were the main things. I think for all of them, you feel just a little off for a couple days. I can't really describe it. It's not like you feel sick, but just maybe a little not as focused, a little brain fog, a little tired, a little just kind of not quite yourself.
Yeah, definitely. So if you were to give other patients advice, now that you've gone through it, what would you want other patients to know before starting PRT?
Yeah. So I talked to a lot of patients beforehand, and everybody seems to have a slightly different experience. And the nurses have said even every visit can be slightly different. So I would talk to people and hear the range of experiences so that you can kind of be prepared. And I guess be a little bit prepared for the worst case in terms of thinking about what foods you want to have available in case you do feel nauseous, what things would you want to eat, being prepared to be a little bit tired and just kind of taking it easy. I live alone, so the isolation part was not so much an issue for me, but that's certainly something if you're living with a family, think about how you're going to manage the distancing from people and the use of bathrooms and those kinds of things. And just sort of thinking ahead about how you're going to set up things so that you don't have to worry about it afterwards.
Was there anything that you wish you had known before starting treatment? Anything that surprised you or was unexpected?
I think well, like I said, I wasn't really prepared for how tired I would feel the day of the treatment. Just how tiring that particular day is. I would also think about the whole scheduling of it. Like, think about the timing. The whole cycle takes about 6 months to get through the 4 treatments. So, I really thought about when is this a good time for me to do this in terms of other things in my life. So I think that's important to think about. It's also, at our hospital, and I imagine most places, they can only do one person a day because of the restrictions they have to have of the room and the bathroom and everything. So, you may not be able to schedule it just whenever you want. So you want to think about how, when it's going to fit into your life. So that would be my advice. I think the other thing is to get really good instructions about the medications for nausea drugs afterwards, or in my case, you prescribe some steroids. And it was funny because somewhere between the nurse and the pharmacy, those instructions got kind of scrambled. So I had to double check to be sure I was taking the right dose at the right time. So I think just, double check with the nurses. The nurses are really helpful, and the nurses have done this with other patients, so they're able to answer a lot of questions. So I found talking to the nurses and also to the radiation technology people really helpful to get advice about how to handle things.
Awesome. Wonderful. Well, I think that's all the time we have, but thank you so much, Christine, for sharing your story. I hope everyone in the audience find this super helpful. Thank you.
Well, I hope so too.
A neuroendocrine cancer diagnosis changes life, but it doesn't define it. In this next Thrivership video, people living with neuroendocrine cancer reflect on how they've adapted to challenges, built resilience, and found new ways to prioritize their quality of life.
While the future may not always be clear, the way we show up for each day still is. Because while uncertainty may be a part of the experience, so is connection, support, and the ability to move forward.
Thrivership is often the result of a negotiation between the patient and the doctor. And the term I love for this, and I didn't come up with it, is shared decision making. That's where I think Thrivership comes from. It's not just being alive, which is obviously one goal. It's being alive with quality of life.
I think it was about almost a year in where I finally realized, and it sunk into place, that I don't need to panic, but also need to take into account that I do have cancer. I had a good understanding of what my disease meant, what the treatment was going to do or not do for me, and how I would move on forward with my life.
There's a time period there where you kind of are trying to adjust to getting a diagnosis. And then the more I read about it, I knew that I needed to understand the prognosis in terms of what I needed to do going forward. You kind of have to come to terms with that. My greatest changes in my life perspective came before my cancer, and that's because I spent 3 years in Vietnam. You walk away from those experiences with a recognition of how fragile life is. It does change how you view things and what you commit your time to, and how you address, the next steps in your journey.
Your world literally feels like it just grinds to an immediate halt, and you're just like, oh my gosh. With a diagnosis like neuroendocrine carcinoma. So to me, the best thing to do is just keep doing what I've been doing. I got my diagnosis. I remember it was on a Tuesday, and I went back home, and I was still working the rest of the day. I actually made calls and did my job. And that was a hard day. I did a lot of crying. I did a lot of, I was really upset. But the next morning I did get up and work out. I did work the next day. There's a lot of uncontrollables in cancer in general. And so controlling what you can and doing the best you can with that. Like, I work out every day. I worked out every day before I had cancer, and I still work out every day. Every day in chemo I worked out. Now, did it change the workout a little? Yeah, especially in chemo it did, but you still just do the best with what you have. And so for me, that's what thrivership really means, is really doing the best with what you have, trying to eat the best you can, get sleep, enjoy life, spend time with family and friends. And that's sort of what thrivership means to me.
I now have large cell neuroendocrine carcinoma together with gastric adenocarcinoma, stage 4, and realized that, somebody told me that I was palliative. I asked, how long does the average person make it? And they said 2 to 4 years. And my head said, okay, first of all, I'm an overachiever, so I'm going for 5. And second of all, if I only have 2 to 5 years to live, what do I want to do with that time? I better get my feet in the starting block, and I better just do it. So then I came up with this whole mantra that I told myself, that's buy the ticket. Don't say no to anybody who invites you anywhere, because you can't just do it next year. You might not be able to. A ticket can be everything from planning a dinner with friends. A ticket means you've got something on your calendar. Now, airline tickets, of course, I did that too. Like, okay, I got all these airline points. If I'm not going to be around to use them, I'm going to start using them. So I did, and I started buying airline tickets, and I started traveling. My baby does the hanky thing. All right. Go up. Okay. So I've never worn a ball gown, and I decided that I have a wedding coming up, and I decided that I was going to go shopping for a gown. And I kept looking and looking and looking, and there was nothing. And then all of a sudden, I saw this gown. And it was like, that's it. I'm living with cancer. But at the same time, you want to live life in a good way.
Now that you've heard about treatments, clinical trials, research, and treatment sequencing, let's focus a little bit on maintaining quality of life and emotional wellness. Leading off our next portion of Know Your Nets is Dr. Kimberly Perez, a medical oncologist. She is assistant professor of medicine at Harvard Medical School, senior physician and co-director of gastrointestinal oncology clinical trials program at Dana-Farber Cancer Institute. Dr. Perez will discuss common symptoms of neuroendocrine cancer, what to expect, and when to speak up.
Hello, my name is Kimberly Perez. I'm a medical oncologist from Dana-Farber Cancer Institute and an associate professor at Harvard Medical School. Welcome to my talk today. I'll be speaking about common symptoms of neuroendocrine cancer, basically what to expect and when to speak up. I have some one-time advisory board member disclosures to share here. And the outline for my discussion today will be basically to discuss why carcinoid syndrome happens, discuss common symptoms associated with carcinoid syndrome, and discuss some of the treatment options that your provider may discuss with you. So, some background. When we think about a neuroendocrine tumor, many patients ask where the neuroendocrine organ is located. And unique to this disease is that the neuroendocrine system resides in multiple parts of the body. And this is due to the embryologic origin of the neuroendocrine system. All humans have neuroendocrine cells in what we call the foregut, which involves thymus, esophagus, lung, stomach, small intestine, pancreas, a midgut, which includes parts of the small intestine and large intestine, and then the hindgut, which is the end of the colon and the rectum. And these neuroendocrine cells, the healthy versions, are located in all these locations because they are the signal pathway for the body. So the brain receives or perceives a situation that it needs to respond to, and it sends signals through the neuroendocrine system by the cells to help coordinate function or response of the body. So you will have neuroendocrine cells sending signals to the heart if you are exercising and your body needs to respond by pumping more blood throughout the body. When you've eaten something, the neuroendocrine cells will secrete signals to the digestive tract to help coordinate function for the digestive process. And if in need of extra oxygen, the neuroendocrine system will help coordinate with the lungs to increase the dilation of the airways in order to optimize oxygen retrieval from the air that's breathed in. So basically, that is why the neuroendocrine cells are found in all parts of the body. The only organs that they are not found in are the lymph nodes, liver, and bone. So, when a neuroendocrine cell transforms into a neuroendocrine tumor, what can happen in a small percentage is that they can maintain their ability to signal. So, as a result, carcinoid syndrome can be associated with neuroendocrine disease or neuroendocrine tumors. The prevalence is about 19 to 35%. Common symptoms that are described are skin flushing, so redness of the face and the chest with a warmth sensation, diarrhea, bronchospasm or shortness of breath, and in some cases, abdominal discomfort. The most common signal that drives these symptoms is an elevation in the serotonin levels. And this can be measured by the metabolite or breakdown product of serotonin, which is 5-HIAA. And commonly, carcinoid syndrome is associated with tumors that originate in the intestine, but can also be associated with tumors that originate in the lung, pancreas, ovaries, thymus, and in some cases, when we don't know where the tumor is originating from, what we'd call unknown origin. And so this is the breakdown. So just another depiction of what I just shared. You have the neuroendocrine tumor cell. It's releasing extra proteins or substances or signals, and they are going to target organs, and the organs are responding. And so this is why you can develop these symptoms, which include the flushing, as I mentioned, the bronchospasm or shortness of breath, the gastrointestinal distress. You can also result in heart disease, valve disease as a result of the excess serotonin, and enlargement of the liver due to the excess serotonin as well. Another slide just to depict that it's not always serotonin. So many of these neuroendocrine tumor cells speak to one another by means of other proteins. Although we check 5-HIAA or think about serotonin as the main protein that is driving the signaling process, there are other proteins that are involved that we don't specifically have assays to assess, but we have determined that they are present and contributing to the symptoms that are present. So I'll just provide an example here in the table that I've included. Flushing can be associated or a result of excess serotonin, but also could be a result of other proteins or histamine. This is just a slide describing why this is happening. And I think I've spoken of this in the last couple of slides, but basically for the diarrhea symptom of carcinoid, you have excess circulating serotonin. This results in stimulation of secretion of the colonic mucosa. You have an increase in peristalsis, which just means the muscular activity of the bowel moving the stool or matter through. And you have decreased water absorption and increased electrolyte secretion, which leads to diarrhea, which is typically associated with abdominal discomfort, fecal urgency. And I share this table to depict the difference between intermittent diarrhea that can happen as a result of gastrointestinal distress from certain foods or just inflammation or irritation of the bowel, where you'll have in a healthy individual, the transit time from mouth to bottom is basically 24 hours, whereas in someone who has carcinoid syndrome, that transit time can be cut in half. What's important to recognize is that diarrhea can be a result of many different issues. And so, always important to consider differentials in the diagnosis, especially in patients with neuroendocrine tumors of the small bowel. Diarrhea can result after surgical resection, which we call short gut. There can also be issues with pancreatic insufficiency over time. So, patients who are on somatostatin analogs like octreotide and lanreotide can over time go from having no diarrhea to developing diarrhea. And so it's not necessarily that they've developed carcinoid, but may have developed with age pancreatic insufficiency. And many times patients who have had primary neuroendocrine tumors in the pancreas or in the bowel may have also had their gallbladder removed. And this can also result in what's called a bile acid diarrhea. So again, important things to consider in patients who have neuroendocrine tumors who've been treated with surgery. Flushing, the other more common symptom that is described with carcinoid syndrome, occurs when it is present over 90% of cases. Again, this is something that needs to be discussed and reviewed with the clinical provider because it, again, is a very vague symptom. Flushing that's typically associated with serotonin excess is intermittent or a persistent sensation of warmth throughout the skin, typically involving kind of the neck, upper torso, and head. And people will describe this kind of burning or warmth sensation that travels upwards. And many women who are in their middle age time period where they may be having hot flashes will describe this flushing as more of a dry flush. So they're not having sweating with it. There are obviously other reasons why people can develop flushing. And that's why, again, discussing with your provider what are other circumstances that may be triggering it. You can have what is called autonomic mediated flushing, which again is part of the neurologic symptoms. So that's where it can be confused with neuroendocrine or carcinoid related flushing. Many patients will develop this with menopause or fever or emotionally triggered. And then there's vasodilator mediated flushing. And this can be, more of the differential is broader. So as a result of rosacea, triggers are commonly discussed or described, medications, alcohol, and other causes for serotonin syndrome. So I'm going to move on to how we treat or help patients manage these symptoms. So it's please tell us what you're experiencing. And now it's the part of the conversation is what do we do with it? And so fortunately, my colleagues and I throughout the world have listened to patients and understood that we do need to provide each other some consensus guidelines as to how to manage these very common symptoms that may be described in our patients who have neuroendocrine tumors that are associated with carcinoid syndrome. So I include this slide just to share that there's multiple consensus guidelines that have been published and describe different means to address and manage the symptoms that I've described associated with carcinoid syndrome. And so I'll start here with this algorithm. Typically, if a patient presents with carcinoid symptoms, the first treatment that is initiated is somatostatin analog therapy. And I'll go into more detail about that and what the options are. There are cases where symptoms may slightly improve, but don't improve enough to impact quality of life in a meaningful way. And so that's important where you then sit with your provider and talk about how much benefit you are gaining from somatostatin analog therapy and where maybe you're still falling short. And so if it is related to diarrhea, let's say that's the symptom that is really triggering the impact on quality of life, then the question would be, all right, you've been on somatostatin analog therapy. The questions are, in reassessing your burden disease, if your disease burden is stable, then do we need to consider other therapies to help mediate the symptom? And there are many options that we can consider. Sometimes I will also consider checking or rechecking 24-hour urine 5-HIAA. As mentioned, that's a breakdown product of serotonin, just to get a sense of how high that level is, and that can help direct some treatment options that are available. If there is evidence of tumor progression on imaging, then that typically speaks to the need to initiate alternate treatment therapy, which is going to control disease as well as control symptoms. So I'm going to move on now to what are the different options for treating symptoms when the disease burden appears to be stable on imaging. The 5-HAA may be up or down, and the patient is still reporting worsening symptoms despite somatostatin analog therapy. So again, as I mentioned, the first line therapy for carcinoid syndrome is somatostatin analogs. This comes in the form of octreotide. The long-acting form of octreotide is called sandostatin. And then there's also lanreotide. This is a cartoon depiction of how it works within the body at the cellular level. So basically, it's administered as an intramuscular or subcutaneous injection on your backside, and it gets absorbed slowly throughout the 28 period between injections, and it is attracted to the somatostatin receptor on the neuroendocrine tumor cells, which it then attaches to and gets internalized into the cell, and that's how it impacts or affects tumor growth as well as release of serotonin or other proteins that are resulting in symptoms. And this has proven to be of benefit because nearly 80% of well-differentiated neuroendocrine tumors have this somatostatin receptor on its surface. And so has proven, not even since the time of the initial studies, which this was first published back in 1986, of 25 patients receiving octreotide, the short-acting version at 150 micrograms 3 times a day, they had 88% reported improvement in flushing. So since 1986, we've continued to use this drug because of the benefits that were not only reported in this very small study, but proved to be the case anecdotally in patient care since that time. After 1986, there was the development of lanreotide, which is also a somatostatin analog, as I've mentioned. And there was the ELECT trial, which was a larger study, phase 3, which demonstrated that the use of lanreotide compared to not to a placebo, meaning the patients did not get any somatostatin analog therapy, resulted in a decrease in the number of days in which they needed to use their short-acting octreotide. And so that was considered a success. And so the results were measured by are decreasing the number of days, so less than 3 days of short-acting octreotide use in a 4-week period. As I mentioned in the algorithm slide, there are some cases where the somatostatin analog therapy isn't quite enough. And fortunately, there is a new drug called telitrostat, which is developed and has been FDA approved for patients who are continuing to experience diarrhea secondary to their carcinoid syndrome and serotonin excess while receiving somatostatin analog therapy. So the Telestar trial was a phase 3 trial, which randomized patients who were experiencing a notable or greater than 4 bowel movements a day related to their carcinoid syndrome to either placebo or telitrostat at 250 milligrams 3 times a day or 500 milligrams 3 times a day. And the idea behind this drug was that, as I showed in the previous slide, the somatostatin logs are attracted to the tumor cells because of the somatostatin receptor that's on the cell, whereas this medication doesn't need to go or affect the tumor cell. It actually is staying within the bloodstream and trying to impact the serotonin breakdown products. And so it inhibits the enzyme tryptophan hydroxylase, which is an enzyme that mediates the rate limiting step to convert tryptophan to serotonin, which mediates the larger or the increased levels of serotonin in the system. So then the breakdown products are then not getting to the end organs like the bowel and resulting in diarrhea. And so these are the results of the study, and a very busy slide, but again, just including it here to share that one, the important result was that 500 was no better than 250. So 250 milligrams 3 times a day was determined to be the dose of choice. And what you can see on C and D of this graphic is that a number of patients all below the main black line are reporting a decrease or a change in the number of bowel movements they were experiencing in a day while taking the medication. And so this is a pretty dramatic response. And as a result, at 250 milligrams 3 times a day, the FDA approved telitrostat for carcinoid diarrhea refractory to somatostatin analog therapy. And so currently, we will offer this treatment and continue it with long-acting somatostatin analogs in order to help control or improve quality of life in regards to carcinoid-related diarrhea. A newer option that was FDA approved in the late 2010s was peptide radionuclide receptor therapy, also called Lutathera. What we've been able to determine, not only is it effective in controlling growth, but it also has proven to be an option for symptom relief. So in the two patient populations, or at least tumor groups or primary sites of disease, pancreatic neuroendocrine tumors and midgut neuroendocrine tumors, there have been studies that have demonstrated a resolution or improvement in symptoms related to carcinoid syndrome. So in the midgut, you can see that there was symptom diaries that patients who participated in the NETTER-1 trial completed. The researchers were able to demonstrate that there was an improvement or a decline in the number of days in which patients were experiencing abdominal pain, diarrhea, or flushing compared to baseline. And in a pancreatic neuroendocrine tumor study of only 23 patients, they were able to demonstrate that there was improvements in blood sugar control for patients who had insulinomas. And there was also improvement or resolution of diarrhea for the patients who had VIP-omas. And so I would not say that we currently use Lutathera PRRT for symptom relief alone, but we do consider it when we have a patient who's presenting with measurable disease progression and symptom relief as an option for treatment, and counsel patients that our hope would be, based on these previous analyses, that patients will get symptom relief with treatment with Lutathera. Another option that is considered for patients who have carcinoid-related symptoms that are not responding to somatostatin analog therapy and potentially not responding to telitrostat is being considered for liver debulking surgery. So unfortunately, there's no prospective trials to compare surgery to other symptom relief interventions, but there have been multiple systematic reviews of smaller studies looking at the benefit or the relief that patients achieved by undergoing surgical resection. And so my colleagues in the surgical field have been able to characterize tumor burden in the liver and evaluated the benefits that patients may gain from resection and the characteristics of tumor burden that would really have a greater likelihood of meeting that criteria. And so what has been described or discussed is that if greater than 70% of the burden can be removed, that's where the benefits are likely going to be seen more commonly. And from these retrospective analyses, you can see that there are patients who have complete resolution of their symptoms in 50 to 60%, or about a third will have some partial benefit from the treatment. And that treatment benefit, because they may still have or likely will have some residual disease left behind, but the symptom benefit can last or persist for 30 to 40% of these patients. So this is definitely something to consider in discussion with your primary oncology team and discussion with a surgical oncologist familiar with neuroendocrine tumors. And finally, I'll just end with another liver-directed approach that has been evaluated for patients who have carcinoid syndrome that appears to be refractory to somatostatin analog therapy and potentially also to telitrestat, is liver embolization for symptom relief. And so liver embolization, there's 3 different types that you may hear about, and they're all transarterial, either using chemotherapy beads, radioembolization beads, or bland embolization, meaning there's no radiation or chemotherapy within the beads that are left behind. And I included this graphic just to provide a sense of how this process works. So the interventional radiologist will gain access to the blood vessel system just like you would for an IV catheter for fluids or medication. And then they're able to, in the interventional suite, access the blood vessel supply to the liver. And they will then be able to access the blood vessel supply, insert beads into parts of the liver that tumors are present, and the beads will be left behind to block the blood flow, and the beads will slowly over time release the contents that can treat the tumors. And again, no published prospective studies that have described the benefits here, but many retrospective reviews or studies have been conducted. And in one retrospective review that included over 5,000 patients, it was reported that almost 55% of patients had a symptomatic response from embolization when the intention was to help control carcinoid syndrome related issues. So in summary, carcinoid syndrome is the most common hormonal complication associated with neuroendocrine tumors and is much more commonly diagnosed in patients with intestinal neuroendocrine tumors. The symptoms typically include flushing, diarrhea, and bronchospasm or shortness of breath. Management is based on the symptom, the bioactive substance that is in excess, and the disease burden. Multiple guidelines have been developed for expert consensus since the availability of prospective studies is limited. And that's where I'll conclude today. So thank you so much for listening, and I'm open to answering any questions.
Our next presentations focus on 2 areas that are impacted by neuroendocrine cancer, but you may not have heard them discussed. We're talking about heart health and bone health. Dr. Tammy Polonsky is a general cardiologist who treats a wide range of cardiac conditions and specializes in the management of heart disease in cancer patients. She is Associate Professor of Medicine and Director of Preventive Cardiology at University of Chicago Medicine. Dr. Polonsky joins us to discuss heart health and neuroendocrine cancer, what to watch for.
Hi, everybody. I'm Tammy Polonsky. I'm a cardiologist at the University of Chicago and really excited to speak with everybody today. What I'm going to be speaking about is heart health in neuroendocrine tumor and what to watch for. So what we're going to talk about today is normal heart anatomy. First, understand the basics so that you can understand how the heart can be affected in adults with neuroendocrine tumor. We're going to talk about symptoms, how to diagnose heart issues, and the treatment of heart issues from neuroendocrine tumor. And then we're going to just talk about some other strategies to optimize your heart health in anybody, whether you have heart issues from neuroendocrine tumor or not. So here's the normal heart anatomy. And what you can see that the right side, so imagine that the heart is facing you. So the right side is actually on the left side of the screen. And that's blue. And that's because our body uses oxygen that's in our blood and it brings it back to the right side of the heart. And you can see on the label there are the valves, the tricuspid valve and the pulmonic valve, the pulmonary valve. And these are the primary valves that are affected when a person has neuroendocrine tumor. And we're going to talk about that in more detail. But the blood goes from the right atrium, and then the tricuspid valve opens, and then the blood goes into the right ventricle, and then the tricuspid valve closes, and then the pulmonic valve opens, that second valve over there, and then the blood goes into the lungs, where you breathe in oxygen, and then the blood is brought back to the left side of the heart. Now, like I said, you can think of the valves like doors that open and close and control the flow of blood through the heart. Now, what happens in a person with neuroendocrine tumor who then develops what we call carcinoid heart disease? This is typically in somebody who has metastases or tumor in the liver. And then the liver secretes the serotonin that then travels into the right side of the heart and affects primarily the tricuspid valve, like I said before, and the pulmonic valve. Now, what happens is that the serotonin causes scarring of the leaflets of the valves, those doors that open and close. And then it also causes stiffening of the lining of the heart muscle so that the heart muscle also becomes stiffer. And then what happens over time is that the leaflets, because they're stiff, they don't open and close as well. And so because they don't open as close, those right-sided heart valves are most affected. And instead of blood flowing forward from chamber to chamber, there can be backflow, and that's called regurgitation. Now, there can also be narrowing of the heart valves, but it's much more common for the heart valves to become stiff and then have the regurgitation instead. And in the earlier phases of carcinoid heart disease, people may not have any symptoms. But over time, when there's extra backflow, it stretches the right side of the heart, and that can eventually get weaker, the right side of the heart, because it's having to pump so much extra blood that it's normally used to. It first starts to get bigger, and then it starts to get weaker, and that's what we call heart failure. So how do we diagnose carcinoid heart disease? A transthoracic echocardiogram, or an echo for short, is the most widely available imaging test. And this allows the team to look directly at the heart valves and to tell us whether it looks like there could be evidence of carcinoid heart disease or not. Ideally, this would be done at experienced centers because sometimes the tricuspid valve and the pulmonic valve, those are the ones that I said are most commonly affected, can be harder to see with echo. And so you really want to have a center, again, that's experienced. And it's reasonable that if any person, when they're diagnosed newly with neuroendocrine tumor, that they have an echocardiogram, again, to look to see whether any of the valves are affected. Because in the beginning, like I said, sometimes people may not even have symptoms. Now, additional tests that might be done, remember that I mentioned that the right side of the heart and the pulmonic valve especially can be hard to see well with an echocardiogram. That's just in all people. That has really nothing to do with neuroendocrine tumor. But because those are the valves that are most affected, you may need additional testing to really get a good look at those valves. In that situation, cardiac MRI can be very helpful as an additional test. And depending on whether a person has symptoms of carcinoid heart disease or not and how the valves are working, your doctors may recommend an echocardiogram or an MRI every 6 to 12 months. Now, there aren't clear guidelines about how often or when a person should be getting imaging. And so that's why I said there's some variation in terms of how doctors might approach that. But certainly having an imaging test at the beginning and then some kind of regular follow-up is appropriate for patients with neuroendocrine tumor. Now, what about blood tests? There is a blood test called NT-proBNP. It stands for brain natriuretic peptide, but I promise it's made in the heart. And the levels increase if the heart is enlarged or swollen, full of fluid. And that applies to people with neuroendocrine tumor or without neuroendocrine tumor. Anything that raises the pressure inside the heart can raise the NT-proBNP level. And so this is just checked with a simple blood test. You don't need to be fasting. And this is another test that your team may check, every 6 to 12 months, or if a person has new symptoms that could be considered a sign of valve problems from neuroendocrine tumor. And that's something that we can follow, again, as another measure to see how the heart is doing. So what are the symptoms of carcinoid heart disease? So when a valve stops working well, and like I said, there can be that regurgitation, there may be swelling in the legs or the abdomen. Sometimes people have all of their swelling in the legs. Sometimes people may just start to feel fullness in their abdomen. They might feel full after they've eaten food. Even if it doesn't seem like a lot of food, they feel really full and bloated. People may also describe chest fullness, shortness of breath, especially with activity. And as the heart starts to stretch more, people may start to feel palpitations, and that would be a feeling of their heart racing, even if they weren't doing activity. So how do we treat carcinoid heart disease? Well, in the early phases, treatment really may only be imaging and blood tests. If we're going to be checking an NT-proBNP, that may be all that is needed, especially if we're seeing that the heart valves aren't really affected very much at all. I would say it makes a lot of sense if there is involvement of the heart valves that a person should have regular follow-up with a cardiologist. Again, that might be every 6 months if the valves are starting to look like they're more affected, or once a year if it doesn't look like they're very affected. And if people start to develop fluid retention, again, that swelling that I mentioned before, then medications that increase urination to help get rid of the fluid, those are called diuretics, then those are used. And the dosing and which diuretic, that would really be individualized to the individual person. Now, valve replacement is sometimes needed when a person really starts to have significant involvement of the valves. This is typically done when people develop symptoms of carcinoid heart disease, but you want to do that before the right heart becomes too weak. Now, I have people in my clinic who I have followed for a long period of time. They've never needed surgery. And sometimes, depending on how their heart is affected when we first meet, we're already starting to talk about surgery. So that course is going to vary quite a bit from person to person. Now, traditionally, the valve replacement is done with open heart surgery, but there are minimally invasive options that are being studied. People who are watching right now may have heard of things like a TAVR, which is a valve replacement of the aortic valve. That's a heart valve on the left side of the chest that is typically not affected by carcinoid heart disease. But we are starting to learn in the cardiology community that we may have options for treating carcinoid heart disease with these minimally invasive options. But again, that would really only be done at an experienced center, and is certainly something that is important to talk about with your doctors. Now, whether a person needs valve replacement or not really requires detailed discussion between all the providers, the oncologist, if there's a surgeon who's involved in your care, if you're thinking about liver debulking. The timing of all of those procedures is really important to think about, because if the heart is weak, that's going to make liver surgery challenging. But if you don't need to fix the heart before a person needs liver surgery, if they're in that position, then there's no reason to delay other procedures or other treatments just because a person maybe has mild heart disease. And so again, another reason to really make sure that all of your doctors are talking to each other. So what else can you do to optimize heart health? Well, blood pressure control helps avoid putting extra strain on the heart valves. And that, again, goes for anybody with heart valve issues, whether or not you have neuroendocrine tumor. And so for most people, if they're diagnosed with hypertension, the goal blood pressure, if they're using medication, is for it to be less than 130/80. A normal blood pressure is less than 120/80. But if a person has already needed medication to treat their blood pressure, then the primary goal is less than 130/80. And other things that you can do to make sure that your blood pressure is well controlled is to measure your blood pressure at home. And it's worth it to talk to your doctor about whether that would be a helpful strategy for you. Now, what about diet? Limiting sodium intake is one of the most important things that we can all do for our heart health. And the goal sodium is to be less than 2,200 milligrams a day. One thing that I talk to my patients in my clinic about is reading labels, because oftentimes foods that are advertised as being low fat, and so they come across as being really healthy, are actually still high in sodium. A common misconception is that if, for instance, somebody's eating sausage or deli meats, that if they switch to turkey products, then they might be healthier. So that's certainly true from a fat content, but in terms of sodium, turkey products usually have just as much sodium as beef or pork. I encourage a lot of people in my clinic, if they want to look for online resources, to go to the American Heart Association website. I put the website up here, www.heart.org. Not only is there just a wealth of information about heart issues in general, it's all geared towards a general population, and it has great resources for heart healthy diets. Unfortunately, there's really not anything, I think, on neuroendocrine tumor and carcinoid heart disease, but just general healthy living and healthy lifestyle. And that's all I have. Thanks so much for your attention.
Dr. Vasil Hareha is Assistant Professor of Medicine at the University of Chicago and a palliative medicine physician at the University of Chicago Comprehensive Cancer Center. He works with patients to manage pain and improve quality of life. Today, he'll speak about bone health and neuroendocrine cancer, managing pain and treatment.
Hi there, my name is Vasil Hareha. I'm a palliative medicine doctor at the University of Chicago. And today we'll be speaking about bone health and endocrine cancer, managing pain and treatment. The objectives for this talk are to discuss the role of palliative care in supporting patients with neuroendocrine cancer. We'll explain how bone metastases develop in neuroendocrine cancer and how they may cause symptoms, and summarize pain management options for patients with bone metastases. Now, to start off with, what is palliative care? Well, palliative care is a specialized medical care and a specialty for people living with any type of serious illness, and it's focused on relieving symptoms and supporting well-being, whatever the diagnosis may be. The goal of palliative medicine is to improve quality of life for both the patient and the family, and I oftentimes introduce myself as a quality of life doctor for people with serious illness. Really, the most common misconception about palliative care is that it's synonymous with hospice, even among healthcare professionals. And palliative care is a broader specialty, while hospice is a subset of palliative care. And palliative care is unique in that it is delivered by a team that includes physicians, but also includes oftentimes social workers, chaplains, and other support staff, and it provides a layer of support for patients and families. And there's good evidence to show that it improves outcomes. So ASCO guidelines highlight that patients with neuroendocrine tumors have distinctive palliative care challenges and therefore really could benefit from palliative care consultation. And the other thing that's unique to palliative care is that we focus on this concept called total pain, which is a concept that pain is not just one-dimensional as in terms of physical pain, but also has concept of social pain, psychological pain, and spiritual pain. So first, let's talk about understanding bone metastasis. There's the seed and soil hypothesis, which really is an older hypothesis dating back to the early 1900s, but holds up well. And the idea here is that tumor cells are essentially seeds and they preferentially colonize organs, which are the soil. And the soil has a microenvironment that is often favorable to that cancer. So bone is uniquely hospitable because it's highly vascular, has a lot of blood flow, it's rich in hormones stored in the bone, and it's a source of cytokines, which is chemical messengers in our body. Some cancers specifically target certain organs, and that's really driven by that interaction with the bone microenvironment. So cancers like breast, prostate, and lung are more commonly spread to the bone, while ovarian and brain cancers rarely go to the bone. The other thing that may be important to know when we talk about bone cancer is that there are different types of bone lesion. Osteolytic lesions means that bone is being broken down, and these often appear as dark and punched out lesions on CT scan. And osteoblastic lesions, on the other hand, they're lesions when new bone is being formed. So often this bone is weak and disorganized. And why does pain result from bone metastasis? Well, there is pressure and stretching from cancer being inside the bone. Also, cancer within the bone can cause shifts in the acid, which can then cause pain. And there's inflammatory chemicals that are released, also causing an inflammatory type of pain. Nerve damage and remodeling, called sprouting, can often happen. And there's also this concept that if you are being constantly bombarded with pain signals, the brain actually gets sensitized to pain. And that's called central sensitization. So therefore, it's important to stop pain when it occurs. How common are bone metastases in neuroendocrine tumors? They're more commonly than historically appreciated. A pooled prevalence across all neuroendocrine subtypes showed a prevalence of 18.4% in one study, and I found another source specifically for small intestines and pancreatic neuroendocrine tumors, also 18.4%. Now, in a study of 213 patients with bone metastasis from China, showed that for that population, the primary sites were pancreas, rectum, thymus, and lung. Bone metastasis in neuroendocrine tumors are more commonly osteoblastic, and they most commonly affect the axial skeleton. So on the left there, you'll see a picture, and so the axial skeleton is kind of that core skeleton, including the spine, the ribs, the pelvis. So 94.6% of people with bone metastasis have axial involvement in neuroendocrine tumors. And I think it is pretty striking that 1 out of 5 patients with neuroendocrine tumors will develop bone metastasis. Now, bone metastasis complications, only about half of people that have a metastasis report symptoms. And the most common symptom here is pain. 66% of people have pain. The late symptoms are common in osteoblastic disease, osteoblastic lesions. And skeletal-related events, you'll see me abbreviate this as SREs as we talk further, occur in 26% roughly of patients with bone metastasis. What are these? These are fractures, so breaks in the bone, a phenomenon called cord compression, which is when the tumor itself in the bone may press upon the spinal cord, causing neurologic symptoms, and something called hypercalcemia, which is a high level of calcium in the blood. That's quite rare in neuroendocrine tumor bone metastasis. These skeletal-related events are more common in osteolytic or mixed disease rather than osteoblastic disease. And anti-resorptive therapy can reduce SREs, and I'll talk more about what that means. So moving on to pain management. The first modality I'd like to talk about is PRRT, which stands for peptide receptor radionucleotide therapy. And PRRT is a targeted cancer therapy. It is prescribed by oncologists and managed by oncologists. I will mention it here because it is some of the NET-specific evidence that we have for palliation and treatment of pain in bone metastasis. You see this Strasberg et al. Clinical trial that I listed. Essentially, this clinical trial found that PRRT significantly delayed time to worsening of pain in people who had bone metastasis in comparison with high dose octreotide. The rest of the evidence for PRRT tends to be retrospective, which is looking back, so not as strong as a clinical trial, but still some compelling studies. So in a study of 74 people with skeletal metastasis, 23 patients had pain at baseline, and over 90% achieved some form of pain relief with PRRT. In another study of 30 patients with extensive skeletal metastasis, there was a demonstration of significant improvement in overall quality of life, not necessarily pain, with PRRT. Moving on to radiation therapy. External beam radiation is kind of a mainstay in management of bone metastasis across most solid tumors. So the data for neuroendocrine cancers is mostly extrapolated from other tumors here. But overall, in other tumors, there is a good pain response between 45 and 90%. And pain usually is noted within 4 to 6 weeks of radiation treatment, plateauing after that. There's also good evidence now that less fractions, fewer fractions, sometimes even one fraction is just as good as multiple fractions or treatments of radiation. The caveat here is that people may need to be retreated. And a prospective cohort study found that overall there was a response rate of 70% in pain. So that's a higher quality study showing good pain result from radiation. And another thing that's on the rise in the radiation world is something called SBRT, which is really high dose and precise radiation. Again, I am a palliative medicine doctor and I am not prescribing radiation, but in my world, I can sometimes refer to a radiation oncologist who can perform this type of treatment for painful metastasis. Now moving on to anti-resorptive therapy. So this mostly takes the form of a class of medicine called bisphosphonates and a medicine called denosumab. There's strong evidence for both in solid tumors for reducing the skeletal events. There really are no neuroendocrine tumor specific trials that are randomized controlled trials, but there are some trials that are retrospective, again, looking back at data. But again, pretty compelling retrospective trials where in one study of 105 patients, 27% of patients that did not receive these medications, the anti-resorptive therapy, had fractures, while 0% of those receiving them had fractures. And another study of 62 patients, Matthew 2023, SREs occurred in 34.6% of patients without receiving anti-resorptive therapy versus 5% of those that were receiving the treatment. Overall, these are actually being used for patients with neuroendocrine tumor. There was one review that I looked at that about 45% of patients with bone metastasis that had NET received bisphosphonates or denosumab. Moving on to procedures. Procedures are mostly used when there is a complication of vertebral fractures or pain that's resistant to other forms of treatment. The most common procedure that's offered for bony metastasis is something called vertebral augmentation, kyphoplasty or vertebroplasty. And it's essentially stabilizing the spine with cement, and that's injected into the spine. And pain relief is reported between 80 and 97% of tumor types. Again, for NET-specific studies, there are retrospective and observational, but there was a study of 19 patients that showed good pain relief post-operatively. And interventional pain referrals, which is a team of pain doctors that conduct procedures, is still part of the treatment team for people with metastatic disease. Sometimes they can offer procedures like intercostal nerve blocks for rib metastasis, for example, which can be very helpful for pain management. And finally, moving on to pharmacologic pain management. This is mostly what I do in my clinic when I see people with bone metastasis. And usually, yes, it is in conjunction with these other modalities that I have mentioned. But for some patients, the pharmacologic pain management may really be a mainstay of their symptoms, especially if they have diffuse metastasis and not just like a focal spot of metastasis. The most common medications used for bone pain are actually probably NSAIDs are very common because they help with the inflammatory component of bone metastasis. Acetaminophen or Tylenol tends to be less effective than NSAIDs for bone-specific pain, but it tends to have a more favorable side effect profile, so we still use it a lot. Opioids are used quite often, especially in moderate to severe pain, and are quite effective for bony pain from metastasis. And then corticosteroids also can be useful for inflammatory bone pain, and especially if people are suffering from that cord compression, nerve compression symptom that I mentioned. Neuropathic agents like gabapentin or Lyrica also often used, as I mentioned a few slides ago, because there is a neuropathic component to bony metastasis. So in summary, bone metastasis and neuroendocrine tumors are underdiagnosed and may be undertreated. The pillars of therapy tend to be radiation therapy, bone-modifying agents, cancer-directed treatments like PRRT, systemic analgesics, that's the pharmacologic treatments, and interventional procedures or surgery. NET-specific clinical trials are needed, and I think some are in the works, but there's still definitely research that is in the pipeline for this topic. And palliative medicine clinicians can help patients navigate serious illness and symptom management, including bone metastasis. These are my references, and I thank you for your time.
Throughout Know Your Nets, we've been talking about physical health. Mental health is also an aspect of neuroendocrine cancer. Emotional wellness deserves attention. Jessica Thomas, LCSW, is NETRF's Director of Patient Education and a clinical social worker with about 20 years of experience supporting patients facing serious and chronic illnesses. She'll discuss emotional wellness in the face of uncertainty.
Hi there, I'm Jessica Thomas. Today's session is a part of our Thrivership program, which is designed to go beyond the medical information and support the whole person living with neuroendocrine cancer. Uncertainty is one of the most consistent themes that we hear about from people. Whether you're newly diagnosed, navigating treatment decisions, or managing a chronic condition, the emotional weight of not knowing can make everything overwhelming. Today, we're going to explore what this looks like, why it happens, and most importantly, practical tools to help you navigate it with greater ease and resilience. Before we talk about tools and strategies, I want to normalize something. Uncertainty feels difficult, and it's not a personal failing. Our nervous system evolved to seek certainty because in early human history, uncertainty often meant danger. When we don't know what's coming, our brains can treat it as a threat. For people living with neuroendocrine cancer specifically, this is compounded by the nature of the disease. In many cases, the cancer can often be slow growing, and patients may live with this uncertain state for years, watching, waiting, monitoring. This chronic uncertainty is different from a crisis that resolves, and it requires a different kind of emotional stamina. But there's good news here. Our brains are also adaptable. We can learn to relate to uncertainty differently, and that's what today is about. I want to take a moment to acknowledge the full range of what a neuroendocrine cancer diagnosis can bring on emotionally. Fear and anxiety are the most commonly reported, but grief is equally as significant. Grief for who you were before, for the plans that you had, and for the spontaneity of life before doctor's appointments became routine. One emotion that surprises many patients is relief. Relief finally after having a diagnosis, and then some guilt for feeling relieved. This is completely normal. For whatever you're feeling today, or what you felt at diagnosis, belongs on this map. Our goal isn't about to eliminate difficult emotions. Our goal really is to build the capacity to hold them without being overwhelmed by them. There's a lot of cultural pressure, especially in the cancer community, to stay positive. And while hope is generally valuable, toxic positivity can actually make people feel worse. It invalidates real emotions and can create shame when someone isn't feeling upbeat. Emotional wellness is not about feeling good all the time. It's about developing a flexible, compassionate relationship with your inner life. It means that you can feel scared and take action. You can feel grief and experience joy. These are not contradictions. Think of it less like a destination and more like a practice, something you come back to day after day, especially on the hard days. This diagram represents what you may experience sometimes multiple times a day. A trigger, whether it's an upcoming scan, a new symptom, or even a well-meaning question from family. This launches into uncertainty. Your brain, trying to protect you, activates an anxiety response. This is a cycle, and the most important thing I want you to notice is that gold box in the middle, awareness. Because the moment that you can recognize that I am in an uncertainty cycle right now, you create a tiny but powerful gap, a moment where you have a choice about how you can respond. And that's not always an easy choice, but it's possible. And it becomes easier with practice. The rest of today's session, we're going to talk about some tools at that intervention point. The first tool I'm going to share is grounding. Grounding is one of the most accessible and evidence-based tools for managing anxiety. Its purpose is to interrupt the spiral of anxiety and allow you to be present in the moment. The 5-4-3-2-1 method is one of the most well-known grounding techniques. When you feel anxiety rising, perhaps before a scan or when you get a call from your care team, pause and work through your senses. What are 5 things that you can see right now? 4 things that you can physically touch? 3 things that you can hear? 2 things that you can smell? And 1 thing that you can taste? This isn't magic. What it does is interrupts the brain's forward-thinking anxiety loop and redirects your attention to right here in this moment. And in this moment, most of the time, you're okay. I want to encourage you to practice this when you're not anxious, and it can become second nature when you are. The next tool is breathing. Breathing is one of the most underrated tools we have, and the most accessible because it's always with us. Box breathing, called 4-square breathing, is used by everyone from Navy SEALs to nurses and healthcare providers to patients to manage acute stress. The pattern is simple. Inhale for 4 counts, hold for 4, exhale for 4, and hold for 4. So let's try this together right now. So we will breathe in for 2, 3, 4. We're going to hold it for 2, 3, 4. We will exhale for 2, 3, 4, and again, hold it for 2, 3, 4. If you do this a couple of times, what you might notice is a slight slowing, a setting. This is your parasympathetic nervous system engaging. Your heart rate begins to come down, and your muscles will start to soften. You can do this anywhere. You can even do it where nobody will even know that you're doing it. You're just breathing. Cognitive reframing is a core technique from cognitive behavioral therapy that can really help people that are living with chronic disease and cancer. Here's the key distinction. Reframing is not the same as being forcefully positive. We are not telling ourselves to pretend things are fine. We are examining the automatic thought, which is often catastrophic, and asking, is there actually another way to see this? If you think of the thought, my body has betrayed me, it may absolutely feel true. But so might, my body's working hard, and I can choose to partner with it. Both can be true. The question is, which thought serves you better? This takes practice. It helps to write down your anxious thoughts and challenge them on paper. Over time, that reframe can become more automatic. Many of the ways we try to manage uncertainty actually can backfire. If we are compulsively on Google searching for reassurance, usually results in finding the most frightening information is more available than the most relevant information. Avoiding all information creates its own anxiety and erodes trust with your care team. One technique that has strong research support is scheduled worried time. This sounds counterintuitive, but the idea is you give yourself time to worry, fully, completely, for 15 minutes, the same time every day. If a worry comes up outside of that window, you can postpone it and schedule to worry about it during that worry time. This teaches your brain that the worries can be heard and gradually reduces the constant quality of your anxious thoughts. Staying in the day that you're in is perhaps one of the most important mindset shifts. You cannot know what your next scan will show, but you can know what you are doing today, who you are with, and what matters to you today. One of the most powerful things we know from psychology research is this: people who feel connected to others navigate illness better, not because connection removes difficulty, but because it transforms our relationships from suffering. When we feel seen, when someone says, I get it, in its own way, that's medicine. NetRF has a community of patients who understand the neuroendocrine cancer experience in a way that even the most loving family members may not. If you haven't connected with other neuroendocrine cancer patients, I strongly encourage you to explore those resources. I wanted to address something that comes up a lot: the difficulty of communicating needs to loved ones. Many of you have people who love you dearly and have absolutely no idea what you need. Teaching them, even with simple, direct language, can transform those relationships. And finally, professional support is not a sign of weakness. It's a sign that you understand the weight of what you're carrying and you're taking it seriously. Scanxiety. This is a term coined by the patient community, and it's been validated by research. This is the anxiety that builds in the days and the weeks before a scan and into the window waiting for results. It's real, it's measurable, and it's extremely common. I want to normalize this completely. If you experience this, you are not being irrational. Your body has learned certain situations can bring significant news, and of course your body would respond. The timeline on this slide gives you a framework for being proactive. Notice where your anxiety starts to build, because if you can name it, you can work with it. The waiting for results window is often reported as one of the most difficult. Having a plan. Who will be with you? What will you do to cope? What can make a real difference? One reframe that you may find helpful is the results are already what they are. My worry does not change them. This sounds simple, but sitting with it can reduce the sense of an urgent suspense. Self-compassion is one of the most evidence-based and I think most underused tools available for people navigating cancer. We are often really harsh on ourselves. We may feel guilty that we're not fighting harder, or for having bad days, feeling too tired, or for being angry. We would never speak to a loved one in the way that we sometimes will speak to ourselves when we're in our darkest moments. There's 3 pillars to self-compassion, and they are mindfulness, common humanity, and self-kindness. Together, they form a powerful antidote to isolation and shame that illness can bring. A simple practice: when you're struggling, place your hand on your heart. Acknowledge that this is a moment of suffering. Remember that suffering is a part of life. Ask yourself what a compassionate friend would say to you right now, and then say it. I want to spend a moment on something that might surprise you. Many patients looking back describe their diagnosis as having brought gifts. Not the diagnosis itself, but the clarity that it created. There's post-traumatic growth, and it's a phenomenon. When we face something that shatters the assumptions of our life, we are sometimes forced to rebuild. And then what we rebuild can be more authentic, more connected, and more intentional than what came before. This doesn't happen for everyone. And this doesn't mean that being diagnosed with neuroendocrine cancer is a blessing in disguise. It means that as humans that we're remarkably resilient and that suffering can coexist with meaning. The reflecting question on this slide is one I'd like to sit with you, not just once, but as an ongoing practice. When you know what matters the most to you, you have a compass for navigating uncertainty. Even when you don't know what's coming, you can know who you want to be. Everything we've talked about today is most powerful when it becomes a system, your personal wellness plan. I want to be realistic though. You don't need to do all of this at once. In fact, if you tried to, that would be a recipe for overwhelm, and likely you might want to give up. Instead, I want to invite you to choose one thing from today and start with it. One practice, one call you'll make, one boundary you'll set. The 6 areas on the slide are a framework. Think of them as the pillars of a structure. The more pillars that are in place, the more stable you feel when one area is shaken. The Neuroendocrine Tumor Research Foundation has resources in many of these areas, mostly from our Thrivership series. And I want to thank you so much for spending time with me today and being here at the conference. I want to close by reminding you of something really important. The fact that you're here, that you showed up for this conference, that you are seeking tools to navigate this is more wellness in itself. And that is already an act of self-compassion and courage. Living with a neuroendocrine diagnosis is hard, and there's no way around it, but you're not doing this alone. The Neuroendocrine Tumor Research Foundation is here, and we are here growing a body of knowledge and practice to help you, not just to survive this, but to thrive in the fullest sense of that word. And that's what Thrivership is all about, and you've taken a step in the direction. Please reach out to Neuroendocrine Tumor Research Foundation for any additional resources. And please know this, your well-being matters to us. Take care of yourself, keep thriving, and we'll see you later.
As we prepare for our live Q&A session, we want to give our Thrivership speakers a few last words. They want us to know that cancer diagnosis often brings greater clarity about what truly matters. Please watch as they share the people, experiences, and perspectives that have shaped their journey and continue to give their lives meaning.
Thrivership. And so I think survivorship understates the importance not only of being, say, cancer-free or having your cancer under control, but still being able to lead a good quality of life in spite of that. Always the most powerful statements are from the patients. And I think their ability to get out there and do things like this and to raise awareness is dependent upon this thrivership. And so it's really about making sure that we're not over-treating anyone, to not be settled for drugs that are good, even drugs that are potentially curative, but to always look to make sure that we may not be able to treat with a less toxic regimen, to make sure that we're personalizing therapy not just in its effectiveness, but in its tolerability and its ability to support a good quality of life.
I remember just thinking to myself, like, how? I'm healthy. Like, I was very healthy. I had just ran a half marathon and I placed 3rd in my age group. I did it in 1 hour and 32 minutes. I'm like, yeah, how? You know, and that's the sad part is a lot of times people think those that get cancer are sick or unhealthy. And I was not unhealthy and I was young, you know, and it has no bias. We all know it has no bias to age or anything, but I remember that crossing my mind, like, how? I knew it wouldn't benefit me in any way to not look at it any other way than I can get through this. I'm not going to be a statistic of, you know, didn't make it or didn't have God prognosis. I'm going to be that statistic that's going to be like, man, we can do this.
My perspective on life has changed after being diagnosed. I try to just take life as it is as much as I can. live day by day, cherish the moments and not try to dwell on the past and also the future. So that's one thing, and it's very cliche, but I've really found that it's helped a lot. And then the other biggest thing that's been a benefit out of all this, I guess you could say, is I started running. I've always hated long distance running. I was a sprinter in high school, and I've always had my own thoughts about running, just being like, hey, the runners are just like the athletic rejects that don't have any dexterity. They don't have any hand-eye coordination, wanted to be a basketball player. So just run in a straight line. But anyhow, I picked up long distance running. I gave it a shot. I had heard about all the benefits, meditative, just being able to challenge yourself and show up every day. And yeah, that sort of culminated ever since I've been diagnosed and up until the surgery, I've been just running. It's like an escape from reality, but it also grounds you physically. I guess with having cancer, you want to try to be as active as possible, and I'm very fortunate and grateful that I have that capacity. I ultimately was able to run a marathon 2 weeks ago, right before the surgery. Not an official one, but I did get it done in a day. So pretty proud of myself for that.
We all know, in some abstract sense, that our days are numbered. Our days are valuable because they're finite. I'm grateful to anyone that takes the time to listen to this. Like, the ultimate currency is time. The people that you choose to share your life with, like, that's the most precious thing you can possibly do. I don't think it's money. I don't think it's material. I think it's time and presence. So this is going to sound very sort of silver lining, but especially when I had my pancreatic cancer surgery when I was 37 years old, I realized, you know what? I can't go through life with the assumption that I'm going to live till I'm 70 or 80. And now I'm 46. And so, I've got patients who are as old as 105. I've got patients who are as young as 15. So unfortunately, cancer is not discriminatory when it comes to age. My dad died at 49, by the way. As he was dying, so his oncologist was very straightforward with him that he was terminal. He finished a book that he had been writing for years, a quote from that book, and I just love it. It's probably my favorite quote from any book, and of course I'm biased. So he says, the crisis of cancer is the opportunity now, however brief or lengthy, to discard the trivial and the shallow, and to fill every moment in relationship with meaning, intensity, and value.
Welcome, everyone, to the question and answer portion of our program. I hope you enjoyed the conference today and learned a lot. And I'd like to introduce our panelists here joining us for the question and answer portion. So we have Dr. Aman Chauhan, a medical oncologist. We have Dr. Xavier Koitken, a surgeon. Dr. Chandrika Chandrasekhar, a medical oncologist. Dr. Kim Perez, a medical oncologist. Dr. Tammy Polanski, a cardiologist. Dr. Udavir Grewal, a medical oncologist, and then Dr. Vaso Hereja, who is a palliative care specialist. And then we have a special guest, Josh Mailman, who is the president of the board of directors of the Neonatal Tumor Research Foundation. So thank you again for joining us, and I'll have Dr. Koitken take it away with the questions.
Thank you, Andy, and thank you everyone for following the program today. We hope you had a good time and you learned a lot. So the first question is going to be a question that relates to surveillance. And the question is, what is the usual surveillance protocol for a primary neuroendocrine tumor in the small intestine after bowel resection and metastatic mesenteric disease? It was a grade 2 tumor. So Chandrika, why don't you tell us how you guys do it at MD Anderson in these particular cases?
Yeah, I think there is a small pool of patients that do get incidentally diagnosed who are able to have such a curative intent resection where the primary as well as the lymph nodes are taken out. In this situation, since we have done a surgery, hopefully carefully looking in the abdomen, everything visibly taken out under the pathology, all good. We're really just looking at imaging scans, maybe even once a year for about 10 years. That's kind of the rough guidelines that are stated. I think I do tell some patients that neuroendocrine tumors, especially being a low-grade tumor, we really probably don't have good data on when to stop surveilling as well. But also we have to balance the effect of like imaging or radiation exposure with scans. Sometimes we get a question, does it matter grade 1 versus grade 2 in the surveillance? I don't think, again, we have very good data to tease out those two apart. We do at this time put them together as grade 1, grade 2, curative intent resection, a surgery, and then about the same cadence of surveillance every 6 months, maybe to every year over time. That's what we do. I don't know if anybody else has different practice about this.
Kim, any comments on this?
No, I'd say in Boston, we're following something very similar. I think another question that arises during tumor board reviews is, what about the patients who have no lymph nodes involved? So I know this question was really in regards to stage 3. Are you still following the patients that may have high risk features with no lymph nodes on that same schedule? And I would say yes, we would follow on that annual schedule. I tend to, because we're following them out for 10 years, and may give them a grace period of switching to every 2-year intervals after the 4th annual image. But I tell people they'll graduate from me or get rid of me at a decade.
Yeah, I agree with both of you. I think that's pretty much what we do as well. In terms of, what to use, is there any specific scans? I mean, we are generally of the and for we, I speak for Andy, I hope he agrees, but, that generally for small bowel neuroendocrine tumor, CT is very good because CT is excellent at looking at mesenteric disease recurrence, right? Because sometimes as surgeons, we miss mesenteric nodes perhaps that are higher at the root of the mesentery. And so an MRI is a lot more tricky to look at those lymph nodes. So CT is very good, but obviously a dotatate PET as well, right? So is there a role to use dotatate PET routinely for sort of early stage nets that are localized? Aman.
Early stage. So one thing I'd like to add, a lot of centers have now routinely been doing universal germline mutation testing for NETs. So, and we certainly do that. So if there are high risks based on germline mutation status, certainly that would be one reason. Higher grade disease would be another reason to do it a little bit sooner, regardless of the stage. But to be honest, all the other risk factor besides the grade, be it lymphovascular status, perineural status, and all those kind of things have largely been not very helpful in prognosticating. So I try to not stress out the patient too much. And I agree with Chandrika and my predecessor, Kim, with the frequency of imaging that they have suggested. That's what we usually do. At 10-year mark, we usually kind of say, okay, now the caveat to that, if we have diagnosed a very young patient who's going to outlive more than a year or a decade, in those situations, I think we can potentially follow patient longer. Our convention of 10 years, it comes from most standard registries because we don't usually follow patients beyond 10 years, and that's become our usual 10-year time frame. But younger patient will probably follow much longer. They have a longer life expectancy. Yeah, so no major differences there.
But I agree with all these things you've said, that the 10-year mark is the important mark, because I'm sure you all see high volumes of neuroendocrine tumors. You all have seen these patients that have had localized disease, have been followed for a few years, and then sort of nobody follows anymore. And then 7 years later, they show up and there are liver mets, right? I mean, all of us have seen this. So I think it's really crucial for our patient population to understand that 10 years sort of the minimum, even if you have a localized tumor. And I agree with everything you've said before in terms of alternating. Perhaps the last 5 years, we do the same. So we'll basically do yearly, and then the last 5 years, we'll do maybe every other year. And the dotatate PETs, we sort of intersperse them sometimes in the middle. So we don't do them yearly. Now, let's switch gears. Uday, what about a metastatic neuroendocrine tumor? So how often do you follow them? And are there specific things that you look for, perhaps, that would make you follow them more often or less often?
Yeah, that's a great question. I think it really depends on, I think this is one area where grade really matters, and also the biology of the disease really matters. There are patients that have very high burden of disease, grade 3. I'm worried about how their cancer is going to respond or not respond to an ongoing treatment. I might decide to scan like sooner, like 2 months, but 3 months is pretty typical for patients that are on some kind of treatment, be it somatostatin analogs or PRRT, targeted therapy, et cetera. 3 months is pretty standard. Imaging modalities may vary. MRI versus CT scan, pretty standard. We all have had patients where liver disease is better visualized on an MRI, so you may favor an MRI. In other patients, CT scan. You can also use dotatate scans every couple years or so, especially more frequently in patients with osseous metastatic disease. There are those patients with low-grade disease where they have been on somatostatin analogs for a while, and we haven't really seen much movement on the scans. So I try to gradually decrease the frequency of scans, maybe going to 4 months or every 5 months or so, if it's been a while since their cancer has actually progressed. But I always tell my patients we can always move these like sooner if we see their functional symptoms getting better or other symptoms associated with their disease burden getting worse in that time duration, so we can actually do them more sooner.
Perfect. Thank you so much. Andy, can you comment on the first question, which is going to be lanreotide versus long-acting octreotide? Is it interchangeably? Which one works best? Is there one in particular that's better than the other?
Yeah, great question. So both lanreotide and long-acting octreotide, they both have two purposes. One is they control the carcinoid syndrome symptoms like diarrhea and flushing. But then the second purpose is they actually keep the tumor stable. So both of them have shown in phase 3 trials to improve what's called progression-free survival versus placebo. Now they are a little bit different. So the lanreotide is a subcutaneous injection, whereas the octreotide is an intramuscular injection, so a deeper injection. So sometimes the patient's body habitus makes one better than versus the other, in terms of the physical needle. And then they also have different pharmacokinetics. So after the injection, how the drug hangs out in your body is different. And therefore, my patients tell me they subjectively experience them differently. And so some may prefer one versus the other. But in our clinical practice, in terms of efficacy, we consider them to be quite equivalent.
Perfect. Thank you. So regarding long-acting octreotide, are there any new formulations that either may be longer acting or beyond 4 weeks, or is there anything that's been trialed out there that we're waiting for?
I said we are waiting certainly for alternatives. If you look at lanreotide and octreotide, especially octreotide has been around for a long time. Longer duration, not yet, but there's definitely another formulation of self-injectable octreotide analog that's completed clinical trial called the Sorrento trial. So we are eagerly awaiting the results. It was designed as a superiority trial. So this was like a weekly injection, if I remember correctly, compared to the octreotide every 4 weeks or lanreotide. And hopefully, if it meets the criteria of superiority statistically, this would become an option. There are some oral octreotide analogs also in clinical trial, but they are primarily, these are what we call non-peptide analogs, so chemical structure is slightly different. At this point, these are being mainly looked into the carcinoid flush or the patients who are symptomatic rather than tumor control as their endpoint. So these are probably the two that are ongoing trials or completed trials that may hopefully increase our options in the future.
Uday, what about side effects? Do you think side effects are any different?
Yeah, I totally agree with Dr. Chandrika. I tell my patients this is like, for me, and that's what I've heard from colleagues as well, it's pretty much interchangeable as far as like getting control of the functional symptoms is concerned, as well as disease control. I echo what Dr. Chandrika said about these newer analogs that are being studied in clinical trials will definitely increase the number of options that we have to offer our patients. I'm particularly excited about the oral somatostatin analog paltusotine that is being currently studied in a phase 3 clinical trial CareFinder, which may provide our patients with an oral option instead of the subcutaneous short-acting somatostatin analogs, and also the Sorrento trial, which may give us another option for both disease control as well as long-term symptom management as well.
I do want to add that I believe the injectable 2-week is also shelf stable and something that patients can give to themselves and travel with. I think one of the real challenges has been for patients having to plan their existence on being in a clinic in every 4 weeks or every 3 weeks. And this may give an option where it's every 2 weeks, but that they can travel with it and not have to worry about showing up at a clinic somewhere in wherever it is they're going.
If it is possible, it'll be truly liberating for patients in that way. Yes.
Yeah, I think that's hugely important, Josh, that you mentioned this, because I was just about to say, quality of life as well as longevity, both equally important, right? When we treat neuroendocrine tumor patients. And as the only surgeon on the panel, I'll put in a selfish plug saying that, at least at our center, when and if we're able to debulk patients that are symptomatic and they become asymptomatic, we generally take them off long-acting octreotide. And we have actually looked at this, and in well-selected patients with favorable biology, that could go for many, many, many years. And so I think that that's something that you mentioned very well, Josh. It is still a burden to have to go every month, right? I mean, there's no question. And sometimes there are labs involved and there are visits. There can be financial toxicity as well. Let's not forget about that, right? So I think these are all really important things that we think about as clinicians, rather than saying, just go on a hormone shot, it's not going to do much in terms of side effect, you'll do well. I do think that there are certainly things that we absolutely need to continue to consider. And I think that as new drugs come on the markets, I think that's hopefully something that we're all looking at and like really excited to trial out. Let's move on to sort of the biology categories. So can a high-grade metastasis originate from a low or mid-grade primary tumor? And talk to us a little bit about sort of heterogeneity between the same tumor, how it can be in the beginning, how it evolves over time. How does that look like?
Yeah, definitely. I think it comes up frequently, especially since we are fortunate to be managing a disease that can act very indolently for a good number of months to years and then inexplicably change its phenotype and so begin to act more actively than we have been anticipating. And so in many cases, those are the patients where I will definitely refer them for a biopsy just to see what's different. And I think there's been more and more times where I'm actually seeing a change, right? Still remaining a well-differentiated tumor in its histology, at least what the pathologists are sharing with me. But I think that the Ki-67 can vary or change. And I think that's really important and definitely leads to very emotional conversations with patients because they've kind of become very comfortable with their grade 1 disease and have kind of put that grade 3 into a category, which I don't have. And that's not my prognosis isn't that. And then to have, a biopsy showing that can be a very thoughtful conversation, but also I'm glad we're talking about it here, is to just share with other patients that it does happen and it may or may not prove to be something that changes necessarily the course or the options for treatment, but will be taken into account.
Thank you. Aman, so let's say I'm operating on one of your patients and it's a metastatic pancreatic neuroendocrine tumor. And the original biopsy of the primary tumor was a grade 1 disease. It comes back in pathology as the primary tumor being, less than 1%. But then I also debulked the liver, and the liver mets, interestingly, show Ki-67 of 17%, right? So now you have to think about surveillance. You have to think about maybe adjuvant therapies, right? There's a trial that includes CAPE-10, right? So how does that matter for you when you have different results on the primary versus the Mets? And then also, which one do you look the most at? Is it the highest, the lowest? Does it matter?
Great question, Xavier. So this is not an unusual phenomena. We come across this scenario all the time. So NET disease is very heterogeneous. And if we biopsy multiple sites, I'm sure we will find discordant Ki-67. Now, usually it's not a problem because most of the time we are still operating within the same category of grade. So maybe 1 and 2% difference, so it's still grade 1 or grade 2. But once in a while, we do come across this completely mismatch, as you said, primary grade 1 and metastatic disease grade 2. Our colleagues from Iowa actually did a lot of work in this. Dr. Grewal, who was trained at Iowa, he would be very familiar. And they've noted that, and Dr. Chandrasekharan, she might be the author on that paper, They've noted the discordance, this could be as high as 30% between the primary and the metastatic disease in terms of the grade. And especially now, we are noticing a lot of these grade transformation as our patients are living longer. It is also be noted that these patients who've been previously treated on alkylator-based therapies, CAPE-10 or PRRT, we are noticing these grade transformation even more. Correlation may not be causation, but we are certainly observing more of these discordance or grade migration, and even morphology transformation from well-different net to poorly different neuroendocrine carcinoma. So you got to be aware of it. To your point, in this particular scenario, certainly higher grade disease trumps everything, and we tailor our treatment, surveillance, everything based on the more aggressive clone of disease, because that's going to be the problem in the longer run.
Yeah, and I think that's the key, right? Is that you get automatically sort of upgraded to the higher. Although I'm sure, we all have seen these tumors as well, just to make it a little bit more confusing, where, there's just the one foci, right? There's the pathologist tells you, well, there's one tiny spot where the Ki67 is high, but the rest of the tumor, everything looks fine. It's very challenging, but
May
yeah.
I add one more thing to this?
Yeah, sure.
And I've seen not one, but multiple cases where we have had pathology reviewed at some of the top net centers, and there is even discrepancies between pathology reads. So I don't want patients to kind of get really fixated at few points. As long as by and large, we are all in agreement, are we operating in a higher grade 2, grade 3, or a grade 1 category? Counting Ki67 percentage could be like counting a large herd of cattle. That's what one of the pathologists told me. So it's not a black and white. We are just trying to understand the biology, and it is just one of the data points. So just take it with a grain of salt as well.
Great comment.
Herd of cattle, and we are from Iowa. We will do a better job, though.
So Andy, on that, I think you bring up a really interesting point. On that, Andy, anything else we can look at to, essentially comes down to biology is king, right? Don't hang your hat on the grade, because the grade may mean something or really not mean much, right? Is there anything else we can do in terms of imaging receptor, so somatostatin receptor imaging, maybe mutations, anything else that we can use to try to predict biology?
Yeah, exactly. There's definitely more beyond just the grade and differentiation and the Ki67, because you can have two patients with the exact same biopsy report, like grade 2 neuroendocrine tumor, Ki67 15%, and their tumors can behave wildly differently. So there's clearly a lot more going on. And all of those things, Xavier, that you mentioned help. If the tumors are totally avid, then those tend to be the more indolent ones, whereas if they lose their somatostatin receptor expression, that may indicate a more aggressive, dedifferentiated clone. Tumor mutation profile also matters. So if we see that the tumor is changing pace, becoming more rapidly growing, and then you do a rebiopsy, and then you see new mutations such as a TP53 mutation or loss in RB, those are all things that are associated with the faster growing neuroendocrine cancers.
Great. Thank you very much, Andy. The next question, Tammy, is whether all patients with well-differentiated neuroendocrine tumor that have carcinoma heart disease, in your opinion, should get an echo. It might be an easy question, but I think there's a lot to go back and forth and talk about that.
Yeah, that is a great question. I mean, I think at least one echo makes a lot of sense because people can feel quite good for a while. And so you could be missing some progression of the valve disease. Now, you could also argue, well, if I feel fine, why do you need to keep getting echoes? You only really need to know when things are worse. But it certainly helps us think about, if a person's going to need surgery, are there other things that we could do to optimize them? Certainly there can be other things that we see in an echo that actually don't have anything to do with the neuroendocrine tumor that might impact how we take care of someone. It can also help us give people a better heads up about what they might look for symptoms. Symptoms can be confusing. The person that you and I recently took care of together who had a lot of bulky disease and had attributed a lot of his abdominal symptoms were actually coming from the valve. Especially since we're talking about a non-invasive test, I think at least one echo makes a lot of sense.
Yeah, I agree with you. in terms of sort of, the symptoms, I think you bring up a really important point, right? I'm sure all of us on the call here have been surprised by results like coming back from an echo where patients were pretty asymptomatic or actually completely asymptomatic. And at least for me as a surgeon, I can ask the usual stuff. I can ask, do you get short of breath, before I take somebody or I can, do you get leg swelling, but I've seen patients that certainly had pretty damaged valves that were pretty well compensated from a symptom perspective. And those are not the patients I want to take to the OR without knowing what I'm getting into, because fluid management in the operating room that we tend to keep dry, especially if we operate on the liver, and then we kind of tend to flood them with fluids afterwards, right? That's generally a bad situation if you don't know what you're dealing with. Tammy, there have been a couple of patients this year that you and I've shared that have had echoes, but then other things have come out of there, right? Like you mentioned, that can also show up. Are there any, including, vessel stenosis
Yeah,
or,
coronary artery disease.
risk coronary artery disease, whatever it is? So are there any tests next to an echo that you think everybody needs to get, or how good is an echo at telling us whether somebody is going to be fit to, like undergo a major surgery if they have a neuroendocrine tumor, or in general, for that matter?
Okay, perfect. Great. So there are two questions we want to get at. How much is the neuroendocrine tumor affecting the heart? And that's predominantly usually the right ventricle. Echocardiogram in general is not an ideal modality to look at the right ventricle if we really need more detailed information, like is this person's fit for surgery? And in that situation, an MRI can really help a lot. And it's really just because of the way the heart sits in the chest that makes echo a little bit less of an ideal modality for the right ventricle. The heart, it sits on an angle in our chest, and the right ventricle, in order to see it, you have to go at a bit of an angle. So it's just easy to under or overestimate how big the right ventricle is with echo. But with MRI, you don't have those limitations. And other things that can be helpful to measure an NT-proBNP level, because the right ventricle might be dilated, but it's actually still managing quite well. And if the NT-proBNP, which is actually a protein that is produced in the heart muscle when it's going under strain, if that's nice and normal, even though the right ventricle is a little bit dilated and still functioning well, that's just another point of reassurance. It's also something that we can follow longitudinally without having to get an MRI each time we want to see the person. If we're worried about things like coronary artery disease, then we're thinking about things like stress tests. I absolutely do not do a stress test on every single person who's going to surgery. And in the general population and neuroendocrine population, that is totally contraindicated just to do a stress test because someone's going to surgery. If somebody's feeling fine and you have no concerns about coronary artery disease, you're much more likely to have a false positive, which has real implications for somebody for an important surgery, because then you're going to do
Absolutely.
an angiogram and delay their care. And so the stress tests we really reserve for people who are having symptoms that make us worried, things like chest tightness, pressure, shortness of breath, especially with exertion. We're really reserving stress tests for those patients.
So I'm with Dr. Polanski, very low threshold getting a baseline echo. But I also want the viewers to know, the patients who are functional NETs, especially with carcinoid syndrome, flushing, wheezing, diarrhea, serotonin-related syndrome, it's a no-brainer. We got to do echoes. We got to keep an eye on it. But there's an entity where are non-functional NETs. So these are asymptomatic patients, like you mentioned, but they are secretors. So they still secrete serotonin and their levels are high. You got to keep an eye on that. So they might not be functional or syndromic, but they can still have high serotonin that can cause detriment to their heart. Since we have Dr. Polanski, I do have a quick question I would like to squeeze in. We scan all our patients for surveillance, and these days our radiologists are very hypersensitive about noting calcification and all those things. What is your advice for patients regarding when they see coronary calcification or aortic calcification? What should be the next steps?
Yeah, great question. And actually, I was one of the co-authors of the 2026 cholesterol guidelines, and we addressed that for the first time. So thanks for the plug. So incidental coronary calcium in the broad population, whether we're talking about people with a neuroendocrine tumor or not, because maybe there's some family members who are watching today as well, we consider that evidence of plaque. And so that, at the very least, should prompt someone to do an assessment of their other cardiovascular risk factors. So blood pressure, cholesterol. Is this a person where they should be taking things like aspirin? It does not mean that a person needs a stress test, because plenty of people can be walking around with plaque that's not affecting blood flow, but it could in the future. And so in my general cardiology clinic, any new patient I'm seeing, I actually look to see whether they had a CT scan that showed coronary calcium. And in a lot of those people, I'm trying to put them on a statin, because even if their cholesterol is not quote unquote abnormal, it's high enough that they developed plaque. If anybody's smoking, of course, we're going to work hard on smoking cessation. And so we take that very seriously, and I look for it in every patient.
Thank you. The palliative care question would be about access to palliative care, right? So in your opinion, does anybody that has a neuroendocrine tumor need to see palliative care? And how easy is it to access palliative care? And what do you see is the major role in these particular situations?
Yeah, I think ultimately we work in the clinic setting. So I have a clinic day where get a lot of patients that we have linked visits with Dr. Liao, for example. And we also receive consults in the hospital, patients that are hospitalized. And in the community, it's still a small part of palliative care, but it's growing. I think ultimately there's just not enough of us to see every patient with neuroendocrine tumor and every cancer patient in general. So I do think sometimes the referrals are reserved for when patients need extra support, when their families need extra support. That may be symptom support, that may be support in navigating medical decisions surrounding their illness and surrounding their goals of care. Ultimately, for the most part, people are getting referred by their oncologist, their medical oncologist, sometimes their as well as their surgeon or radiation oncology. At some institutions, that is a requirement. At University of Chicago, we see our patients. At other places, I think they're a little bit more open in that people can self-refer, for example. I will say maybe a non-trivial amount of my patients are people that are seeking out palliative care. They've heard about it and they say to their medical oncologist, "Would you refer me to palliative care?" So I think that we can scale up our visits and see people more often if it is needed, and scale down if patients' diseases are controlled and maybe their symptoms are controlled. But I do think it's sometimes good for us to get involved early, meet people, and then kind of scale up or scale down to how much support a patient may need.
So what do you bring that Dr. Liao can't? If I'm the patient, I'm seeing Dr. Liao as a phenomenal medical oncologist, what does palliative care actually add to me seeing Dr. Liao?
Absolutely. So I actually think that if a patient has a symptom, Dr. Liao is on it. He's trying to manage that symptom, and he's probably doing a wonderful job at it, right? But I think if Dr. Liao feels like I need a little extra help because this is a more complex symptom, then he's referring to me. And it's likewise with support around medical decision making. I think if the patient needs a little more time, somebody that maybe has an extra amount of time in their clinic slot to really talk through a decision, talk about a person's values and goals, then we can do that, and we can work as a team together, Dr. Liao and I, to figure that out. So I think often is actually your medical oncologist or your surgical oncologist or the radiation oncologist saying, "I need a little extra help here."
Yeah,
This is
definitely. Our
phenomenal.
palliative
Thank you.
care colleagues, Vaso and all of you guys help our patients so much, right? With the complex pain regimens or difficult to manage nausea from the chemotherapy and things like that. Those are things that we try to do, but ultimately you guys have the better expertise and know like how better to manage those.
I'm dual trained actually in palliative and medical oncology, but I cannot emphasize, like what Dr. Hera mentioned about like sometimes you really need that focus, attention, focus time. Sometimes it's a style of communication. Sometimes it's just how you say the same thing. I'm sure that's true for even like a non-medical setting when it clicks, how well it clicks for some situations. For me, the conundrum, especially in neuroendocrine, is always about when to refer or who's the right person to refer. I think these are evidence-based, not really supported. Like there's no such timeline guidelines or things like that. But I think one thing the patients have to realize is when I wear my palliative care hat, I think of myself as, I say, quality of life doctor. And so anytime the patient feels their quality of life is beyond the medical measures done by an oncologist, not where they want it to be or like it to be, it is very reasonable to ask for a palliative care consult. So sometimes I just call it the quality of life doctor for that reason.
That's how I introduce myself to patients. I'm a quality of life doctor for people with serious illness. Yeah.
I love it. This is phenomenal. Thank you. All right, next category, PRT. We haven't talked about PRT yet. Okay. Kim, first question would be, with PRT, do all patients get the same dose, or does it depend on patient weight? And then I'm going to throw in a little Koitkin question, which is, where do you see the role of dosimetry in PRT?
Oh, a little curveball. I like that.
Yeah, that's a hard one.
Probably because the first question is pretty straightforward to answer. So there is one dose that the teams will apply to all patients, and I think it's really the adjustment in the dose is driven, or changes in it are driven by other medical issues that they may be concerned about toxicity. So whether or not someone is coming into it with significant baseline renal dysfunction or hematologic issues, that's where a dose adjustment would be made. So it's not like the other drugs that we prescribe as medical oncologists, where we're using height and weight to really direct what the dose is going to be. Dosimetry, I think I would say, as a non-nuclear medicine clinician, I think that I'm anxious to see the results of the studies that are underway that are going to help us use this in real time. I think that is where we'll be able to personalize this very effective treatment for individual patients and their disease burden.
Perfect. Yeah. So not enough data yet, but certainly perhaps one day we will use dosimetry routinely. For patients, obviously, dosimetry is essentially a way to track how much radiation is getting delivered to the tumor, as well as to the vital organs, for example, the kidneys, the bone marrow, the liver. And so not every patient will metabolize or kind of, use the PRT drug the same way. In some patients, there'll be more radiation that get hung up in the kidney, for example. In some patients, more in the liver. And so tracking the toxicity is important because every organ can only get a certain amount of radiation over a lifetime. And so you can imagine that if we know exactly how much radiation is going to a specific organ in a specific patient, we may be able to give more doses, right, over time, rather than the 4 doses, Kim, that you said, are sort of the standard of care, 200 millicurie, 4 doses, and that's it. And then obviously the other aspect of dosimetry is how much gets into the tumor. That's a whole different question as well. I'm going to go to Uday next. The outcome of doing a second round of PRT. What do you think about that? Does it work? Does it not work? Any particular patient you would use it on?
Yeah.
Or maybe some you wouldn't?
Absolutely. I think it definitely works. We need prospective data. Currently, all we have is retrospective studies, both from European and North American centers. So I think the big challenge is, since we don't have prospective data, we don't know how to appropriately select patients for repeat PRRT. Something that I have used in my practice is I select patients based on how much benefit did they derive from the initial round of PRRT. What we know from retrospective studies is that the progression-free survival, or for how long their cancer benefited from PRRT, that duration is halved when you get a second round of PRRT or repeat PRRT. So I like to at least see a 1 year of progression-free survival or 1 year of benefit with the initial round of PRRT, so I can at least give hopes for around 6 months of benefit with a repeat round of PRRT. The other thing that we don't know is from NETTER-1 and subsequent studies like NETTER-2, we know that initial round of PRRT will be 4 treatments of PRRT given 2 months apart. But do we really need all 4 cycles when we give repeat PRRT? We really don't know. That's something that is being studied in a trial called ReLuth, which is a French trial, and that will shed more light on it. But in my practice, I try to advocate for just 2 treatments of PRRT in the repeat PRRT setting. And that's because we know that the maximal benefit that we get from PRRT is from the first 2 cycles, because there's a significant drop in the levels of somatostatin receptor expression after 2 rounds. So I typically go for 2 rounds of repeat PRRT in patients that have at least demonstrated disease benefit or progression-free survival of 1 year with initial round. And that is also for patients that have preserved kidney function, and also their blood or hematological parameters are within acceptable acceptable range. I know your next question to one of the panelists is going to be alpha PRT, but I just want to say this is one of the spaces where we are really hoping that alpha PRT will help us fix a huge unmet need once we have data from the recently concluded Action 1 clinical trial.
So where do you start that 1 year from? Is it from the last round? Because many people start the 1 year just like you would do any other drug from when you start the first dose.
I think it's worth the toxicity that comes with repeat PRRT in patients that have at least had a year of benefit after the last treatment. Dr. Chauhan is one of the PIs on the NET Retreat study. We'll see if repeat PRRT really increases the risk of long-term hematological malignancies like MDS, AML. Existing data shows that it does not, but we still don't have that data. So I'm subjecting a patient to that possible increased risk of long-term hematological toxicities. I really need to have a strong rationale to use PRRT where at least I can promise them 6 months of disease control with a repeat round.
Very good. And I think, again, this may perhaps be something, I don't know, where dosimetry could perhaps play a role as well, right, in retreatment. I mean, should everybody that undergoes retreatment perhaps get, dosimetry? These are all questions that I think that we need to answer.
Yeah, I mean, dosimetry, there are largely two schools of thoughts. If you go to SNMMI, there's a big push for dosimetry. But in medical oncology world, we are a little bit more pragmatic, I would like to believe. So the bottom line is, currently, all the clinical trials which will be practice informing either resulted or are going to result or are currently enrolling, none of them are incorporating dosimetry to guide treatment.
Right.
So for next 10 years, I don't foresee dosimetry will be meaningfully employed in clinical decision making. Secondly, the problem is 80% of cancer patients in the United States are treated in community setting, not in academia. Theranostic as is pretty labor intensive, needs a lot of infrastructure requirement. So unless we break down this dosimetry to much more simplified way where we have centralized way to upload the imaging and the software using AI and then give smaller centers would not be able to hire a physicist and all those software needed to do dosimetry. So I think those are some headwinds towards the dosimetry application. But to the point, it makes sense. PRRT or drugs like radioligand therapies were designed or were meant to be more precision-based, more tailored to individual patients' needs. So the idea in theory is very attractive.
Perfect. All right. Andy, tarlatamab, can it be used for metastatic PNETs?
Yeah, great question. So tarlatamab is a drug that targets a marker called DLL3, and it's a bispecific T cell engager. And these drugs are in clinical trials and have generated a lot of excitement for the faster growing neuroendocrine cancer. So for the extrapulmonary neuroendocrine carcinoma. So one example of a drug like that is obrixtamig, which has shown very, very encouraging data from phase 1 trials. I'm sure Dr. Chauhan's talk mentioned this. And now this is being studied in a phase 3 clinical trial, actually. So I think the preliminary data is very encouraging. This is for the faster growing neuroendocrine cancers.
So as a general question, maybe the last one for the panel, hope is probably the most important thing that patients have. And hope means hope for a good quality of life. It means hope for living a long time. And that is automatically related in modern medicine with new therapies, right? Because new therapies is what gives us as clinician hopes that we'll be able to cure patients one day, certainly make them live longer. So if you would have to look back over the last 10 years on how much progress we have made for patients with metastatic neuroendocrine tumor and rate it on a scale from 1 to 10 and how you expect the next 10 years are going to be, can you tell me how have we done? And how do you think things are going to look over the next 10 years?
I would say it's all in the published data. I mean, all the dates that the recent discoveries and the drugs that have been FDA approved have all taken place over this last decade and just over. And so I'm so very much encouraged by what our current colleagues and predecessors were able to achieve and get out to our patient population. And if we continue on this trajectory, I it excites me to be part of this field, because if we keep on this trajectory, we are going to hopefully double the options that we have available to our patients, and it will include therapeutics that we had not foreseen being an option, and so I'm curious to see where that takes us. But I definitely feel like, especially and with the colleagues on this call and colleagues that we have, worldwide, we are going to do that for patients.
Yeah, I think if I have to rate it, I think we have done an 8 or a 7 in the past decade. I think there's a scope for 9 or 10. And I think that's because there is focus, there's dedicated effort, there is, foundations like NetRF and others that are also like really making concerted effort for research, amazing patient advocacy groups, scientific organizations. It's not quite an orphan disease like it used to be. I think that is the biggest change. And I think we are looking at new and novel treatments and existing options, refining them. I think that's important as well. So it's a great place and a great time to be there in this field.
Couldn't agree more. I think we've come a long way, but there's a long, long way to go. My sincere hope is, in addition to what my colleagues have said, I'm really here for seeing more precision oncology-based treatments being made available for our patients. And one such example is not just targeted therapy, but also immunotherapy. And I think there is a role for it. We're going to get there. We're going to find a way to make immunotherapy work, but also in addition to what we're doing for well-differentiated neuroendocrine tumors, I think a huge unmet need has been more high-grade, poorly differentiated neuroendocrine carcinomas, where we have not even had a standard of care. I mean, that's saying something. So I'm really hopeful that we will, with DLL3 targeted therapies and other therapies, we will be able to move the needle for those patients as well.
Yeah, I agree with everyone. I think we're really, really taking off as a field. I've never seen so many new breakthroughs and discoveries as in the past 5 to 10 years in our field, and all thanks to brilliant researchers and doctors and foundations to support our work, but also to the patients and family members, because they sacrifice so much and participate in all of our clinical research, clinical trials, and making all of this progress possible.
Well, it's been like a dream run for neuroendocrine oncology. I very vividly remember the NANETs where 3 practice-changing studies, the NETTER-1, RADIANT-4, and TELESTAR study were announced. And I think there was only standing room. Me and you probably were just at the end of the hallway. That was sort of the pivotal shift in a field where we were kind of going with gut feeling. We now are into evidence-based medicine. And since then, there's several other randomized clinical trial and several are actually ongoing. So that has been a huge win for neuroendocrine oncology. I'm very optimistic, but we will not stop till we find a cure. And to Uday's point, I think with us trying platforms like vaccines, CAR-T therapies, T-cell engagers, novel immunotherapies, and normal combination therapies with radioligand, I think the sky is the limit.
Okay, well, you've heard it from all of us. We have done pretty good, so pat on the back. Thank you to foundations like NetRF that have funded a lot of this research as well. There's a lot more work to do, but everybody on the panel agrees that we are going to tackle this. We're going to continue to put a lot of time and effort in this, and there's a lot of hope. So I really appreciate it. Thank you for being here today, and we will see you next year.
Thank you for attending Know Your Nets and spending this time with us. We hope you have learned more about neuroendocrine cancer and ways to manage your physical and emotional health. I want to thank Dr. Xavier Koitkin and Dr. Andy Liao for their leadership. We are grateful to all our speakers who shared their time and expertise. We're also grateful to our Thrivership participants for their perspectives and hope. Jennifer Rogers Anderson, Paige Correnti, Jackie Dong, Barbara Dunham, Dr. Mark Lewis, Jamie Metzel, Gary Murfin, Jessica Ochoa, and Sherry Schultz. Know Your Nets reflects our team's dedication to patient education, led by Jessica Thomas with Jennifer Long and Anne-Marie Green. Rich Tamayo is our video producer, and Josh Millman, the president of the NetRF Board of Directors, participated in our Q&A. Know Your Nets is co-sponsored by University of Chicago Medicine. We are grateful for support from AbbVie, Boehringer Ingelheim, Curium, Crinetics, Exelixis, ITM, Lantheus, Novartis, and RayzeBio. There are many more resources for you on our website, netrf.org. Check out our NetWise podcast, Thrivership videos, our patient guide, and much more. If NetRF has been helpful to you, please support us. We depend on community support to advance research, so people with neuroendocrine cancer will have more treatment options. You can visit our website to learn more about our Breakthroughs Today, Cures Tomorrow campaign. Remember, NetRF is here for you. You are not alone. Thank you so much for attending Know Your Nets.